know, maybe you were not there, yeah, the announcement at that time. But if you are here today, you just want to give us a feedback about yesterday, about the hands-on workshop. The floor is open right now before we start the lectures. And also for our online viewers, we also welcome you to day 2 of the workshop. All right, so feel free to talk to your neighbor, feel free to talk to somebody beside you while we network, we also learn. All right, yes. Anybody ready for a feedback before I call our director to give us a warm welcome this morning? Anybody? You want to share what you have learned so far? Okay. I'm going to probably, okay, please come. All right, I'll bring the mic to you.
Thank you. Good morning, everyone. So, my name is Comfort Ajelu from Biomedical Engineering Department, University of Ibadan. So yesterday was an high hope now to the need for MRI, and beyond the need for MRI in a hospital, and also looking at the population in Nigeria, the available ones, and how they are not yet to take care of our healthcare needs. We need to build capacity to be able to produce our own MRI, to build capacity, to be able to manage, to be able to use it. And I think this workshop is very relevant in time like this, and looking forward to more engaging time during this workshop and even after. Thank you.
Thank you very much. That's coming from a biomedical engineer. It means you are set for us. So that we know that once the MRI is on ground, we have people to be able to manage it. Any other feedback? Anybody bold enough?
Hello, can you hear me?
Anybody?
Can you hear me from Italy? Nivedita here.
And we can.
Great. Well, wonderful. And I hope you all are very good starts. I'm here waiting for the time it comes to give a lecture. It seems sunny out there.
Hi, Neve. Can you hear us?
Yes, I can. I can. Can you hear me?
I can hear you loud and clear. And good.
Lovely, lovely. Where are all the women of Africa? Where are they?
They're still coming. We had a little bit of delay, but we're building up.
Yeah. All right.
We miss you so much, but it's good to see your face finally.
I can tell you I miss you all a lot as well. I'm really sorry I can't be there today.
No problem. We'll do with this. All right. So thank you. So let me hand over the mic. Okay, let me just have the mic to our MC.
All right, thank you so very much. I'll take one more feedback before our director welcomes us and we kick off the program. Anybody? You want me to bring the mic to you? I'm going to give you, sir. You're smiling.
Okay. I didn't want to because I came from biomedical engineering, so I don't want it to be a monopoly. Anyway, I think something that I took from the yesterday's event was the need for low intensity MRI, which is like giving us a research focus in terms of what we need to be looking at. And more especially that we have power challenges, and there's a need to look in this direction so that we can have MRI that can consume less of energy. And equally, I think one other thing I also took from yesterday's meeting was they need to have it as a bedside device. Presently, we have it as something that has to be somewhere and with a lot of challenges in terms of setting up. So I think I feel very happy to actually know, because I'm actually asking, what are we contributing really? But coming yesterday, I mean, actually, it's like giving a direction of where we need to be looking at. Thank you.
Thank you very much. Thank you very much. So we're also going to set the ground rules. Let's all keep our phones in silence. If you need to take your call, please excuse yourself from the hall and be sure you are the next person by your side. So right about now, I will invite Director of Smarter Africa Network, Ogbole, to welcome us to this day 2 session, and then we can kick off live and direct. You are welcome, sir. Let's put our hands together.
Thank you, thank you, thank you. Well, I just want to say that I'm so excited that finally we're able to pull this together and have a workshop. Like you know, there's no program that does not have its challenges. But despite all the challenges, I'm glad that yesterday went very well. And we got to meet each other. We got to meet new people, make new connections, and learned a little bit about MRI. And I'm hoping that today is a more relaxed atmosphere, but it's going to be slightly intense because we're going to have lectures back to back. But we're going to try and make it as relaxed as possible so that we can have also interactions. We've had a bit of delay this morning, but I'm sure in the next 5-10 minutes, we'll kick up with the first lecture. And once the lecture starts, I think everything will run smoothly. We're hoping to have less interactions, but please, if you need anything, please don't hesitate to put your request on the chat group. There's a WhatsApp group for every member of this workshop. So if you have a need, please just send a query there and then somebody will attend to it as much as possible. We are happy this morning to have one of our resource persons who was not able to make it yesterday to join us at this meeting. So I have the privilege. Where is he? James G. He stepped out? Okay, he has stepped out. Loading his file. Okay, all right. Okay, James G, actually, we will get to meet him. He came all the way he's from the University of Pennsylvania, Philadelphia. He traveled all the way, more than a 12-hour trip to be with us here. He came in yesterday, so he couldn't join us, but he will be with us and he'll be giving the lecture later this afternoon. But I'm happy to. Hey, let's give him a round of applause. Hey. All right. So he's joining us, and we're happy to have him. We're also, I just want to use this occasion to thank the members of the local organizing committee for a great job. They have actually gone through 7 hills and 7 mountains and 7 rivers to be able to put all this together. So let's give them a round of applause. I would like to especially appreciate the local the state or local organizing chairman, Dr. Ayodele, for her team, and also our regional LOC chair, Professor Ikpeme, for helping us put a lot of things together. So please, if you need anything, you can grab either of them. If you need food, you need a place to rest, you need money, you need, just grab them. They will settle you. Thank you very much. And just to say that Today is going to be, like I said, back-to-back lectures. We're going to have lectures, have a tea break, just look at the program, and then we're going to have the breakout sessions later in the afternoon. Tomorrow is going to be very, very unique. We're also going to have a master class. Tomorrow we come in with our t-shirts, our sneakers, and our jeans. Because we're going to be moving around. We're going to go to several MRI centers, and we're also going to have time to move around. We're going to have a team. The biomedical engineers will be practically also going back to see a center, the biomedical engineering display studio in Ibadan. So they'll be traveling for about 2 hours to Ibadan to see the design studio. And that is going to be organized by Professor Dari, who is the head of Department of Biomedical Engineering at the University of Ibadan. Professor Dari, can you give us a wave? So there'll be a dual, kind of dual educational and social and should I say engineering tourism. And then tomorrow as well, we're going to have our dinner, which is going to be a special dinner, very traditional African dinner, where you're going to see a display of African culture in terms of fashion. Our invited guests are also going to come in their own traditional attire. We're going to make them Africans. We're going to officially induct them into the African culture. So be ready to see African culture, African dance. Tomorrow, and that program is going to be held at the Providence Hotel. And it's going to be a wonderful thing, but it's optional, purely optional. And you can get the tickets from the registration stand. If you have not already got your tickets, you can pick up your tickets at the registration stand. It's going to be a good time. And then on Saturday, we're going to have a tour of Lagos. And most of you know that Lagos, like I said yesterday, Lagos is a place where there's organized chaos. And it's a place where you can find gold in the dust. And it's a place of what? Unlimited opportunities, where you can become broke in one day and you can become a millionaire in one day. You understand? So it's a very unique place, a place of beauty and a place of, you can see a lot of junk if you want to see junk. But it's a beautiful place. It's a mixture. It's a place, it's a diverse city. And we welcome you to enjoy that opportunity to take a tour of a fraction of the city, because Lagos is so vast. We can only take you through 10% of the city, but we're going to take you to 10% of the best places. And that program is going to be led by our indefatigable Mrs. Balogun, who is going to be. So take off time. She will be giving us more details as we go along. And I'm sure everything will go fine. I just want to thank you for your participation yesterday, and we look forward to an enjoyable time. Okay, so welcome again to this 4th MRI workshop of the Smart Africa Network. This network, I'm sure some people have been engaged with this network for over 4 years. And I'm going to give, maybe tomorrow, we're going to give it time for them to give testimonies. Those online and those offline, those are present here, will give you the testimonies of what they have benefited. One of the key things I can tell you is the mentoring opportunities that we have provided, the networking opportunities we have provided, and the collaborative opportunities we've also provided for several people around the world, especially in Africa. And we're hoping to do more. And we want to thank our global partners for supporting us. And they are the pillars of this network. Thank you so much for being part of this network. And I'm sure things will grow. Like I said, next year is going to be bigger than this, because we are collaborating and we are like a segment of the International Society of Magnetic Resonance Imaging. And next year, the conference in the entire world is going to be held in Cape Town, in Africa, in South Africa. And this is the first time it's been held in Africa, and Smart Africa is going to be part of that program. We're likely to have a 1 or 2 day workshop prior to the meeting, and I'm looking forward to having everybody here in Cape Town. Cape Town is a lovely place, very expensive, but a lovely city to visit. So I can encourage those of you who are, who are worried about, oh, it's expensive. You can plan for it. You can save towards it, and you can look. There are going to be opportunities for travel grants from several organizations, both from ISMRM we are also going to make opportunities to reach out to our sponsors to assist people to also attend the program. So thank you so much. And without much, I want us to jump in and hand over to the MC for this meeting. Thank you very much.
Thank you once again. Can I confirm from media that we are all set? All right, thank you. So we all have the virtual program. If you can see them just at that place to drop your slides so that it's going to be easier to make your presentation. So we're going to hit the ground running now and start with the first lecture, which is Introduction to Advanced ASL Imaging Beyond the Measurements of CBF. And that is going to be taken by Daniel Wang. Okay. We give him time to sort that out. After that, we have the application of the ASL in pediatric population that will be taken by Nivedita Agarwal. So please get ready with your slides while the third lecture, Quantification in ASL, Measuring Cerebral Blood Accurately, will be taken by Benjamin Aribisala. Okay, and after that, we go ahead to have a tea break, and we take 2 more or 3 more lectures, and then we have our lunch. Like Prof has said, it's packed, but it's in a relaxed atmosphere. Just enjoy yourself while you learn. So Danny Wang, yes. Thank you very much. Let's jam our hands together for him.
Hello, everyone. Good morning. Yeah, I've been in Lagos 3 days, 2 days. Yeah, I had the boot camp. I was very energetic. I'm very impressed by the curiosity and the energy of the students. I gave the same lecture for the graduate student in the United States. I think all the students understand it and they ask very interesting questions. Yeah. So today I'm going to talk about a little bit more advanced techniques. Yeah, so. Yeah, by the way, I'm a professor at, I was originally trained in China, then I came to United States, actually working with Jim G and at Penn for 10 years. And I'm a professor at University of Southern California in Los Angeles. Then I'm also representing, I don't know if you see, yeah, I'm also representing an organization called Overseas MI Community, Overseas Chinese MI Community. Yeah, so I'm the upcoming chair for OCS MRM. So I'm trying to do more outreach in Africa. Please go forward. Yeah, this is my disclosure. Can you remove this one? Yeah. Mm-hmm. Okay. Yeah. Please move forward. Yeah. Yeah, so today I'm going to talk about several interesting technologies with ASL, especially with 3D Picasso across field strengths. We actually collect data in Nigeria. Some latest like a vessel selective, velocity selective, dynamic angiograph. And also, you know, now we couldn't do anything without AI, right? Especially in Africa with low field and portable MI. Now, talk a little bit about new technique we have been working on. It's about the blood-brain barrier, looking at the blood-brain barrier water exchange. Then some clinical applications I interleave. Yeah, please advance. Yeah. So this is the slides. You saw it before. This is basically how ASL works. So it was actually introduced first by my mentor, Dr. Thatcher in University of Pennsylvania 30 years ago, more than 30 years ago. So the way it works is really using radio frequency and the gradient pulse. You basically magnetically label the water molecule in your own blood. So you are not injecting anything, you're not giving any radiation. You're basically using your own blood water as endogenous contrast agent. So please, yeah, so when you put a labeling plane at base of the brain, yeah, please advance, yeah. Then please, yeah. Yeah, so I think the display didn't go, it will go through the labeling plane, then get magnetic labeled, then you image within your brain. So of course, you know, your signal is the combination of the tissue and the blood signal. So you always need a, please advance, yeah, you always need a control position. Advance, yeah. So you keep everything the same except you don't label the blood. So for example, you can put on top of the brain. Of course, this is an older technique. We have more advanced technique now. And then you subtract, then you can get a flow image. So this technique is very nice. It's basically a green technology, right? You don't basically consume any external contrast agent. The drawback is really the signal to noise ratio is very low because you know the blood is only arterial blood. Artery is only 1% of your signal, your total tissue signal. Then the signal also relaxes with the T1 of blood. So T1 of blood is generally on the order of 1 to 2 seconds. It's lower at a low field, high at a high field. So at 1.5 T is only 1.3 seconds. At 3T is 1.65, but at 7T it can go to 2.3 seconds. So the high field is better for ASL, yeah. So the way we're doing is we basically average. We average many times, so you can get a perfusion image 5 minutes. Then you can also quantify in this perfusion units called milliliter per 100 gram per minute. Yeah. So advance, please. Yeah. And so used to be, we have two techniques about 10 years ago. So I just, you know, this is very similar to a nuclear medicine methods called a positron emission tomograph called PET. So in PET, you inject radioisotopes, right? For example, O15, water, then you kind of detect the radiation across your head, make an image. But in this case, we use magnetic labeled blood as the endogenous tracer. We detect the labeled signal. So you can do the continuous labeling. Just I introduced to you, you have a plane, right? Turn on for 2 seconds, then you label all the blood flows through this plane. Or you can do pulse, which is you basically just instantaneously label the blood that below the imaging slice, right? So you can label a relative 6 slab of blood. So this is called a pulse. So it's basically trading space for time, right? So in terms of, so the continuous ASL is better for SNR, but technical more challenging. So last 10 years, this technology has taken off. It's called pseudo-continuous ASL, so PCASL. So this is the technology that is combined the benefit of both continuous and the pulsed. So right now, when you buy a new scanner, you should always ask of the vendor, do you provide a 3D Picasso? So that's the one you should ask for. Yeah, please advance. And so about 10 years ago, 2015, so a group of ISMI expert, actually, we went to Amsterdam, have a workshop just like this. And the people feel, you know, because there's a lot of different techniques in the field, and people don't know which one to do because there's continuous pulse, pseudo. So then people actually come up with a method. Basically, they write a consensus paper. So this is called ASL white paper. So that one, you know, basically they suggest Picasso with background suppression and with a 3D acquisition. So why is it because 3D is because the SNR is higher than 2D. So this actually helped a lot with the field, at least with the industrial manufacturers. So they all now come out with a product of matching this recommendation. Yeah, so this is helped a lot with the field in terms of kind of standardize, harmonize the field. So this is actually a 3D image, very beautiful. About isotropic 3 to 4 millimeter resolution, we can get routinely on all the scanners in general. Right now, if you buy a scanner, when you ask for 3D Picasso, I think they should provide. They should provide you. Yeah. Please advance. Yeah. So this is actually very nice. We did the pre-training boot camp in Radia in Lagos. So we actually scanned. This is Iris. Iris is one of our professors. So she was also an expert in SL. So we said we tried. This is the 1.5 United imaging. So she basically just did 2 scans. One is just resting, doing nothing. Then also another one was doing the finger tapping, only right hand for 4 minutes. So this is the resting. This is the finger tapping. What you notice is actually here, I don't know if you can see it clearly. So this part is very bright. You know, this part, this is the omega, we call omega, the hand grip. Yeah, maybe a little bit up, yeah. So she's very excited. We didn't do any, it's basically off the scanner. The scanner provides a color map. So I actually did a quick post-processing. So we added the color bars. So yeah, you can see. It seems, you know, the second scan globally is a little lower. We don't know why. Maybe she got more relaxed. Yeah, so it works. This is just off the scan 1.5 T. You can do in 4 minutes, 4.5 minutes. Yeah, please advance. Advance. Yeah. Oh, this is the arrow. Yeah. So we also did for example, this is post-label time of 1.25 seconds. Post-label time is how long you wait, right? You know, you label here, then you wait for the blood to go into your brain, right? So the shorter you wait, the higher signal, but some signal may be in the blood, right? In the vessels. So we call arterial transit effects. So we did a short one, it's 1.25 seconds. We did a long one, 1.8 seconds. So you can see the SNR is lower in the 1.8, right? Why is that? Why is that? Yeah, it dies with the T1 relaxation, right? So yeah, so it's a little tricky, you know, because 1.5 T, you don't have a lot of SNR. So in general, you know, we would recommend 1.8. That's what the white paper recommend. But in Africa, seems people, the blood flow is very high, I feel. Yeah, yeah, we don't see a lot of Bessel signal here. So yeah, so that's something you need empirical adjust. But overall, the blood flow value is very close. They're like a 50 globally. Yeah. Okay, advance. Yeah. So a new technique recently in recent year is really, we talk about different delays, right? If you delay short, you have the Bessel signal we call arterial transit effect. If you wait too long, the signal dies, right, with the T1. So it's very tricky. You need to pick the middle, right? You need to kind of reaching the balance between the two. So what now ideally is we call multi-delay. So it's like you catch the dynamic curve. It's like a DSC, right? On the boot camp, we talk about the dynamic susceptibility contrast. So this is the new technique called multi-delay. So multi-delay, like this image, you have 3 delays, 900, 1500, 2100. This is, you get a CBF and another time image called arterial transit time, which means how long take the blood from the labeling region to your brain, right? So you get both parameters. Just like a DSC, you get CBF and CBV and also MTT, right? Advance, please. Yeah. So like this one, this is a normal ATT map. So this is the ATT map of a carotid artery disease. So you can see there's area with prolonged arterial transit time. Usually means, their blood supply is affected, right? Maybe not low, but it's affected. So you can see it. Yeah. You get more information. You get better, you get a more accurate quantification of CBM. Yeah, please advance. Yeah. So this study was done by the Stanford group. So they use a very advanced scanner called a PET-MI. So it can do PET and also can do MI at the same time. So they did a gold standard, which is the PET using the radioisotope of O15 water. So that's considered the gold standard. Then this is the multi-delay, this is the single delay. This is the difference. So you can see the multi-delay has smaller difference than the single delay compared to the gold standard. So multi-delay is the most accurate in terms of right now the quantification. Yeah, please advance. Yeah, so this is just a map, this is actually of United 3T. So it's actually, you can get CBF and ATT, beautiful images, isotropic 3 to 4 millimeter resolution. Yeah, please advance. This is just the same image. I just display, all the slides together. So you can see, maybe back a little bit. Yeah. Yeah, so you can see the ATT is always lower in the lower slice, a little higher in the superior slice. Then also posterior is a little longer, right? Yeah, posterior is, please.
I want to know how you do the labeling. So that you inject it through an IV access, intravenous access. And I also want to know what the various colors represent, because you say that when you do the pulse continuous AS, have a better signal to noise ratio. Okay, and then you are showing various colors on these images. I'm seeing green, red, and blue. What do they represent? Thank you.
Yeah, so the question is how do you perform the Picasso labeling, right? Yeah. So, today, because the time, I didn't include very technical detail. Yeah, so basically it's used, in MI, you basically use 2 things. One is the radio frequency, which we call B1. Then it's the gradient, it's the gradient field. So basically, we use these 2. Yesterday, Matera talked about a little bit about MI. So basically, we can manipulate the spin by program this pulse sequence to do the spin labeling. So it's basically use the radio frequency pulse combined with the gradient. Yeah, so it's the pulse sequence programming, basically. Yeah, yeah. So it's the effect is very similar, like you put a labeling plane there. You can control it, how long you apply, where you apply. Actually, yesterday when we do boot camping, we can visualize the labeling plane. Yeah. Some manufacturer provide the visualization of the plane, where you put it in the carotid artery, where you put, and also you can control the power, basically how much power you give to this labeling. Yeah, so we call B1 and the radio frequency pulse. Yeah, yeah. So yeah, so we talk about the ATT pattern. The posterior is a little bit longer. The watershed is a little longer. Anybody can answer my question, why the posterior is a little longer? Posterior circulation is more complex. Okay. It's like a vertebral versus to basilar and to PCA, right? Yeah, you to make it a turn. Usually the flow velocity is lower than the MC, right? AMC, ACA. Yeah, so the PCA usually is a lower flow, slower flow. Yes, yes, yes. Okay, please advance. Yeah. So you can also do this onto 1.5 T. On the radial scanner, we don't have this multi-delay sequence. So, but you can ask the manufacturer. You say, I want to do some research. I wanted the multi-delay. Can you provide? A lot of manufacturers they provide research sequence. So it's called work in progress. So you can ask them for it. Yeah. In 1.5 T, because signal to noise ratio is a little lower, but you can do is you can basically just use a thicker slice, right? A larger voxel. It's 2 times SNR. If you double your slice thickness, then you can gain the SNR back, right? Yeah. Okay, advance. Yeah. So you can also do very interesting technique. For example, it's called vessel selective labeling. So this is very unique. I don't know if in Africa you do the intervention radiology, like a DSA, stroke intervention. So when you go in, you go one vessel at a time, right? You inject left IC, right IC, then also vertebral, so left, right, and the posterior. So you can do this with ASL as well. Yeah, non-invasively. You basically can label the left, label the right, label the anterior, label the posterior. So the time is a little longer, but you can do it completely non-invasive. You don't need to inject anything. You don't need to do the catheters. Yeah, so, okay, yeah, please. Yeah, so this is a study we did. Basically, we look at the AVM, some arteriovenous malformation. So you basically label left IC, right IC, post PC, and you want to tell, how much blood is supplying this lesion, right? This AVM. Then you can do surgical planning, right? And this one we compare to DSA is a very, very good, yeah, please. Very, very good accuracy. Yeah, 95% the AUC curve. Please, yeah. Another technique is we talk about, because, we label, then we wait, then we do the image, right, for the perfusion. But if you don't wait, you immediately acquire signal. You can get the arterial signal, right? You can get the angiograph, right? You can basically do an angiograph out of, if you don't wait, right? Because the labeled blood is all in the arteries, right? So you can actually do it, please advance, yeah, continuously, please, yeah. You can get this dynamic angiograph without doing any injections. You can do injection as well, but this one's without contrast agent. Yeah, please, yeah. So this is a movie, this is a big AVM. So you can see it goes in, goes in, some are PCA, some are MC. Then it goes in, then it goes out with more like a vein going to the sagittal veins. Yeah. So this is actually all without contrast agent. So this is 100 milliseconds temporal resolution, and also isotropic 1 millimeter resolution, spatial resolution. Yeah. So this is a new technique called a dynamic angiograph. Yeah. Please advance. So the limitation of ASL, is a very useful. Yesterday, the commissioner even talked about, make ASL the best practice in Lagos. So all the African, they do like a tourism for healthcare. They will come to Lagos for ASL scans. Yeah. So it has many advantages, also it's very economical, and doesn't have any environmental impact, doesn't have radiation, doesn't have contrast agent. The key limitation is low SNR, right? We talk about. Then also the arterial transit effects. We talk about it will be, you have to pick your delays, right? You can be too short, can be too long, which cause difficulties. Yeah. Okay, please advance. Yeah. So one of the latest is really try to use high field. So in the Western countries, has been really the push for high and ultra high field, right? Right now, I think 3T has become mainstream. Right now, we have 70, the whole world is more than 100. Europe, 50, probably United States and Canada is total 34. China has more than 10. And also 5T, United Imaging has 5T whole body. So really try to, because the SNR is scale with the field strength, comes with a price. So usually it's 1 Tesla per million, without the siting cost, the construction and all the electricities, all this. So yeah, so really there's a push for high field. Yeah, I think in Africa, you're getting a 3T, right? You're getting the 3T as a couple 3T more 1.5. Please advance, yeah. Yeah, so this is actually 5T image. So this is 3.5 isotropic resolution. It looks maybe not so striking compared to 3T, yeah. Please advance. Yeah, but you can do higher resolution. This is isotropic 2.5 at 5T. So you can really start to look into more details. Please advance. This is 70, 70, we can reach isotropic 2 millimeter, right? We can reach isotropic 2 millimeter. So this is the tumor, and you can obviously see the tumor, right? Then this is the moya with the ischemic lesion. Yeah, we can actually, in our lab, we can do isotropic 1 millimeter. Yeah, that's mostly for research, not for clinical. With 1 millimeter, you can answer a lot of detailed questions like perfusion change across the cortical layers and all this in aging and in dementia, whether the hippocampus was, which part of the hippocampus was affected. And yeah, please. Yeah, so also the 70 give you better contrast for angiograph. So this is the dynamic angiograph I just introduced to you. Actually, some vendor has the product. I know Philips has the product. United has the product. Yeah, Siemens probably it's a whip. You have to ask of them for it. Yeah, so it's give you very, very sharp images. Very nice image. Please move forward. Yeah. Another technology, of course, is AI, right? You know, with the low field, right now, even with the regular field, you can use AI to shorten the scan time, right? With low field, you can bring the image quality up comparable to high field, right? So this is actually very popular right now. It's also low cost, very fast. So I think the AI is very much. But please go back. Yeah, that one is we did a comparison with the AI. We made a cartoon with it's a AI technology, deep learning based. It did not. So we actually applied this on the 1.5T, also collecting in Nigeria. So this is without AI. Please. Yeah, so this is with AI. So it does clean up the image, you know, get rid of all the grainy noise. Yeah. Please advance. Yeah. Yeah, please advance. Yeah, so these are side-by-side comparison. You can see, you know, with AI, without AI, the improvement. Yeah, so I think the AI is definitely a way to go. A lot of manufacturer now, the scanner comes with AI. Yeah, almost all manufacturers comes with AI. You just have to ask. Yeah. You can either shorten the acquisition time or you can increase the signal to noise ratio. Yeah. Okay, please. Yeah. Another technique you probably heard of is called velocity selective ASL. So you instead of, you know, we talk about we are all performing spatial labeling, right? So the blood flows through this labeling plane will be labeled. But there's because it takes time for the blood to flow into the brain. So that causes arterial transit effects, right? So another way to do it, a very ingenious way, is really you label all the spins that is moving. So you can have a cutoff velocity very low. So you basically label all the blood within your brain that is moving, which is in your blood vessel. It can be in your small blood vessel. So it's very close to where you want to image. Right? We talk about perfusion is microvascular flow. So this is called velocity selective. So the idea is because you are labeled so close to the imaging, you don't have these transit effects. So yeah, so this is a very elegant technique. Yeah, please advance. Yeah, so this is a comparison of, this is the velocity selective ASL, this is Picasso. Yeah, so they are getting to very close. They're they're the quality. The VS, I think there's no commercial product. But maybe you can ask the manufacturer. You will say, you know, I want to do some VSASL in Africa. I think they will help you. Yeah, yeah. Sometimes I think you just have to be. You ask for the right question, right? So a lot of manufacturers, they do provide this capability. You just have to ask. Yeah. So very interesting, you know, you notice actually the CSF is very bright in the VS cells. This is because, you know, CSF is also moving, right? You know, CSF is moving with your heartbeat. The CSF is going up and down, up and down, up and down. So the CSF will be labeled by velocity selective. So sometimes it has artifact, but the signal is getting very nice. Please advance. Yeah. Yeah, for example, this is a Moyamoya case. So if you use Picasso, if you don't do very long post-labeling delay, you get these ischemic lesions, right? You also get a lot of vessel signal called arterial transit. But with VS, you can get the perfusion, right? So the VS idea was try to get the real perfusion. Yeah. Please advance. Yeah. The last a few slides, I'm talking about a little bit about the dementia. I think dementia is a global pandemic, right? Because people live longer and population are growing. But there's a risk of dementia in every continent, developing, developed world. And the risk is double every 5 years after 65. Yeah, so it's a very, very costly disease. And it put a huge burden on the healthcare system as well as the families, right? You have a demented, family member, then the whole family needs to taking care of it. So dementia is a real, right now, real global health kind of challenge. So yeah, so right now, U.S. You have drugs, very, very expensive, slow down the progression, but you have to use this positron emission tomograph to do the diagnosis. You detect the beta amyloid burden in your brain. So if you're positive, you qualify for the treatment. If you're early, you qualify for the treatment. Yeah, there's a new blood assay come out as well. So I think in Africa, the PET is very rare. Yeah, so actually ASL can, in a way, perform very similar function as PET. So this is just to shows you from cognitive normal to subjective memory complaint to mild cognitive impairment to Alzheimer, the blood flow keeps going down. Yeah, if you advance, yeah. Please play the video. Can you play it? Yeah. Yeah, this just shows you the 3D rendering of, the blood flow pattern goes down with Alzheimer's disease. So it has a global decreasing as well as posterior cingulate, especially with the temporal parietal and also the precuneus. Yeah. So in a way, ASL can do something similar to PET. Yeah. Please advance. Yeah. Then, I'm spending 5 minutes talking about the blood-brain barrier. So the blood-brain barrier is, please play this video. You advance it to play. So, you have this cilia top. So this is called blood-brain barrier. It's very protective. It doesn't allow any toxic material to enter your brain. But it also allows, oxygen, glucose, and all these nutrients to passing through. So the blood-brain barrier permeability is very important. It is kind of impairing a lot of disease, including dementia. So used to be you can only inject gadolinium contrast agent to image the permeability, right? You use this, what we call dynamic contrast enhanced DCE-MI. And you have enhancement in tumor, that's obvious, right? You use T1 weighted then. But recently there's a lot of technology using arterial spin labeling to image the water permeability. Yeah, so please advance. So this is a cartoon. Shows you this is the this is the blood vessel. Yeah, please advance. Yeah. So this is water molecules. So it will cross out. Please advance. Yeah. So the water molecule is very small. So that's very sensitive to BBB functional change. Please advance. Yeah. And it has multiple pathways. It can diffusion. It can go through ion pumps, like a sodium potassium pumps, and also can go through this water channel called aquaporin 4. Yeah, so this is a very hot topic. Yeah, please advance. Yeah. So how do you do this with ASL? is you have labeled the blood going into the capillary, then it will go through this BBB into brain tissue, right? So these two compartments has different T1, T2, and the diffusion coefficients. So there's different ways you try to separate them, right? So I'm not going to detail. When you separate them, you can estimate how fast, the water goes through this BBB, and you can calculate this, what do we call water exchange rate, right? Yeah, please advance, yeah. Yeah, so this is some animal study. So we use this technique, use diffusion weighted perfusion to separate these two compartments, because the capillary has faster diffusion, right? Faster pseudo diffusion. The tissue has restricted diffusion. This study, they use animal to validate. They use this technique called mannitol injection. So this is a drug that will open up the BBB when you inject in the arteries. So this animal's BBB was opened on this side. So you can see actually, the KW is the water exchange goes down. This is using contrast agent. This is the contrast agent goes into this side of the brain. This is using histology. You use Evans blue staining. So very interesting. You can see the BBB water exchange rate goes down when you open out the BBB. It's very interesting. Compared to K-trans, it's an increase. Yeah, and also it shows dose dependence. If you have a high dose of mannitol, you actually decrease more. So the interpretation is, it affects the AQP4, the water channel function. But nevertheless, it shows, it's sensitive to BBB functional change. Yeah, please advance. Yeah. Yeah, so in AD, this is a study, the data is from China. This is the normal patients. This is the cognitive normal subject, but they have the A beta positive. They use PET or blood test. They're A beta positive. This is cognitively impaired with A beta positive. So these are sick people. These are asymptomatic AD. This is normal people. You can see this trend goes down very obviously, and it correlates with a lot of cognitive changes. Yeah, so it does indicates the BBB impairment in dementia. Please go next slide. Next slide, yeah. Yeah, so this is also a small vessel disease. I don't know if you heard of this small vessel disease called CARDICEL. Have you heard of CARDICEL? No, you heard of CARDICEL. Very, I think it's not very rare in Asia and Europe. Relatively rare in United States. Probably, I don't know if Africa has a study on CARDICEL. Yeah, but this is a genetic disorder, genetic small vessel disease. So they kind of damage the smooth muscle. So HTRA1 is the second common small vessel, genetic small vessel. So you can see also the KW goes down in this disease. So yeah. Okay, please move forward. Yeah. Okay, so we come to the conclusion. So I'm just trying to introduce you to some more advanced technology. These are very new, even in Western countries, a lot of in research. But I think, it's not out of reach for African. I think, especially, for example, Velocity Select AI, I'm sure Jim will talk more. And also, some latest technology. A lot of time you just have to ask the question, right? You just have to, when you purchase the scanner, when you ask the salesperson, ask for the service person, but you do have to understand its use, right? And also your population, right? If you have, for example, you have a lot of sickle cell disease, right? I think they are very much affected by hemodynamic function. BBB, right? Also HIV. HIV is very much affect BBB as well. Yeah, so I hope I kind of introduce you some latest advanced ASL technologies. You may be able to practice using your research. Thank you very much. Thank you.
All right, let's put our hands together for Danny Wang. He still has some 5 minutes to his lecture time, so we'll take questions. But for me, the idea of ASL is more relaxing. I don't know how many of us have had MR done. Anybody in the hall, you've had an MR? Yes, any other person? Oh, thank you. Well, I did my CMR in the UK, and you know what it means, disclosure. And the radiographer brought me in and said, "Hi, Elizabeth, you're gonna have this, you're gonna have contrast being injected." And she went on and said, it's not any problem, but that she's using gadolinium and that there are very few reactions being recorded, only that those few are fatal. I forgot I was a radiographer. And when she was advancing the table into the MR gantry, I actually said my last prayers, and she gave me an instruction, close your eyes. I said, what is it? Is it not this gantry we are seeing? And I opened my eyes. It was a 3 Tesla. And the journey was like, it was not ending. And I started imagining being laid under the 6 feet. And I started panicking. And the next thing, I had to call to be taken out. And she said, calm down. I said, no, take me out now. And she did. I'll tell you the rest of the story. But for ASL, I'm sure since no contrast is going to be used, if I had this opportunity at that time, it was not brain, I had the CMR actually. So my own question to Danny will be, can this tagging also be used for the heart, for CMR? Okay, that's my question to you. Let's give him a mic. So if you have any question, please ask him. He still has a few more minutes to his time before we call. All right, you want to take that?
Yeah, we talk about this during the boot camp. Yeah, CMR, we show the images. CMR, but it's very challenging. Because everything's and yeah, I know you want to get it quickly. I am, but you.
Okay, so we are stuck with that. Next question, who is helping with the mic? Any other person, raise your hand now so that we know how many people we have.
Presentation, Danny. So I just want to ask for the fact that look,
Mhm.
there's no contamination from
Mhm. Yeah, so that's a very good question. Right now, for example, regular ASL you control by spatial, right? The space you label, where you label, so that you can select which vessel, even left or right, anterior, superior, posterior. The velocity, you can select basically based on flow velocity. Yeah. Mhm. Yes, yes. Yeah, I think, if you want to avoid CSF in general, you probably want to the velocity a little higher. So your label, because the CSF is slower than the blood flow. Yeah, blood flow is generally 10, 20 centimeter larger vessels. Yeah. So but then you are labeling the large vessel again, you are going back to the Picasso. So that's a kind of struggle. If you go too low, then you're also labeling the CSF. Yeah, so there's another technique I didn't get into. It's called background suppression. You can try to suppress the CSF. So it's like a flare, right? Flare is CSF is dark. It's the same thing. But there's some challenges in this technique for the velocity. So it's all very active research area. You're asking very good questions. Yeah.
All right. So I'll take you. Yeah. Give him the mic. And hello, sir. You'll be the last person. Oh, is somebody here? Okay, yeah. Okay, after him. Please go ahead.
Okay, thank you.
Say your name and then ask your question, your affiliation and your question.
Mhm.
To find or to purchase a pot of gadolinium, because it costs an arm and leg, So with this presentation with AirCell, I feel like it's gonna be helpful. Yeah, because we've had cases whereby we send patients back because they can't afford a pot of contrast. By the way, I was also worried when you said on low field MLI, you have low signal. So I was thinking about Malawi now, like, here at Malawi, they have 4 scanners. One is so I was class. So I was like, I guess Malawi. But you showed that with AI, it's possible. Then I'm over the moon. Thank you.
Yeah,
Thank you very much.
We can do it here. Yeah, Well, we did on the radial scanner. Right? We did. Yeah.
Thank you. John Sobungalot from Uganda. I don't know much about ASL. I just want to understand if you're measuring perfusion, for instance, what would be the normal range where you'd say somebody is normal, this one has some issues? Is there standard or it is patient specific?
Yeah, so in general, the white matter is about 20 milliliter per 100 gram per minute. So gray matter is about 2 to 3 times higher. So yeah, so it's 40 to 60. Some a little higher. Yeah, in general, so that's the ballpark range. So the global is about 40, 50. We showed we measured the iris is 50. Yeah. Yeah, so that's also age and gender dependent. So that's why I show that at boot camp we have this developmental curve. So you have the children is very high, then they start going down with aging. So it will be very nice to have a normal curve of African population, right? Together with other modality like volume, for the gray matter, white matter, and all for some key brain structure, hippocampus. So this way it's like a growth curve, right? When you see a doctor for your children, you know where they are, right? Are they grow too fast or too slow? So yeah, so this we have to have a reference, have a benchmark.
Thank you. Please.
Thank you so much for your presentation. My name is from Eastern Nigeria. You showed us images of what you did with 1.5 Tesla in Lagos here. 3 Tesla. So my question, are there some people doing studies with low field MR? Because maybe with time, even the 1,000, 100,000 the prof from Uganda told us is a bit on the high side for some places in Nigeria. So I want to know if there are studies on low field MR considering the ASL. Thank you.
Yeah, so I'm not too aware of what you mentioned is portable MI and the ultra low field. I think it's below probably 0.5. Yeah, because in our university we have a 0.55, which is the max, right? The max for free max. Yeah. I saw some colleagues trying it. I didn't see very nice image, because the T1 goes down with field. Yeah. But the T2 is longer. So there's some idea about instead of using T1, using T2 for the spin labeling, but it's not. Yeah, I haven't seen a good study on ultra low field using ASL. Yeah, it's the signal to noise ratio is gonna be very low. Yeah.
All right. Thank you very much. And that will bring us to the end of that lecture. Let's put our hands together again for Professor Danny Wang. Oh, there's a question online. Please write it down. We also going to go to the general question and answers at a point. And so all our jotters are biros. Let's drop our questions down. We'll create time to have a Q&A session after all the lectures. So we're going straight without much ado to the second lecture for today, applications of arterial spin labeling in pediatric population. This will be delivered by no other person than Nivedita Agawa. Let's put our hands together for her. She's going to speak online to us. So we don't know what the time is. It's good afternoon or good morning from Lagos. You have the floor, please.
Good morning, everyone. Good morning. I am 1 hour ahead of you, so it is a very beautiful morning. Can you all hear me clearly and loud?
Yes.
Okay, wonderful. All right then. Well, first of all, apologies. I cannot be there in person. I know many of my friends are on in the meeting today, and I really apologize. I just couldn't come. So let's do some of the applications of ASL in pediatric populations. Some of this material I will discuss in the masterclass later today so that we have enough time, to go through all the lectures this morning. Let's see. All right. Now, I had put some common questions, and Danny Wang has already responded and explained most of this. But just for completeness, I will go through all of these questions, right? So what is ASL? And I'm really talking mostly to clinicians here. We are usually very lazy, and we let technicians and radiographers and bioengineers do everything for us. But I think it is very important for us medical doctors to understand the basic concept of the sequences, in this case, ASL. What does ASL measure? Okay. Why are we thinking of doing ASL in children? What could be the major killer clinical applications for ASL in children? And as you already asked several times, can it replace gadolinium-based perfusion imaging? Okay. And I'm happy to share some basic literature on this so that you can start going with this. Now, the first very quick survey I'd like to ask you is, how many of you have an MR with ASL sequence? Tonia, can you help me with this?
Thank you. Please, those who have, because I have a 1.5, but I'm not sure. One of JNCI, please, can you answer that? Uche.
Just a show of hands, how many of you have an ASL sequence on your MR scanner?
One center.
One center.
Just one center. So it's not good enough. And it hasn't even been really installed, or we've not been trained on its use. But probably at this, they would install it and train us. Thank you.
This is a good start then.
My center with 1.5 Tesla has a GE Signal Explorer.
Okay, wonderful. All right. So what is ASL? Now, again, this is a repetition, but just for the completeness of the whole talk, I'm going to go through this. So it's a non-invasive method, and it as non-invasive as an MRI can be. So you don't have to puncture the patient, no access to veins, and of course, no gadolinium. You assess, what do you assess? You assess cerebral perfusion. You assess tissue perfusion. You're going all the way down to the microcirculation, okay? It is a T1 weighted imaging. This is going to be important for you to understand, and that is, and I'll tell you this at the end of the lecture so that you all remain awake. It, of course, doesn't use gadolinium, right? And it can be a good replacement for a PET or a SPECT scanner. Now, yes, most of you may not have PET scanners. I don't have a PET scanner in my institution, which is to say that if there is good perfusion, then there is good metabolism as well, or vice versa. If a brain tissue has a good metabolism, it is also perfused very well, because it is all to do with the neurovascular coupling, all right? So it can give you an idea of FDG PET-based metabolism in the brain. So ASL is great, right? It's a 4 to 5 minute sequence. It's not very long either. Again, you know this, it's easy in the sense that it acquires a set of control sequences. So without any kind of labeling, then you wait for some time, you get a labeled image, you subtract the two sequences, and you get a map. You get a grayscaled map, which is right here. And then again, because we clinicians are very lazy, we color it up, right? And there's an international code. We color it up. The brighter, the more red the area is, the higher the perfusion, the blue or more black it is, the lower the perfusion. And I would urge you, as soon as you start getting your ASL maps, look at the color map, but also give a look at the gray map. And I have an example for you for this. Now we're talking about children, and we did, and I've heard Danny talk about PLD, and I'm sure you heard about this in your workshop. PLD is one most important parameter to set up your ASL. You get that wrong, you will get wrong images and you will get wrong interpretation, okay? PLD is that number, it's that time where you can see this in milliseconds, okay? Which is feed it into the scanner, you put it in the scanner based on, usually it's based on age. I mean, one of the parameters why we put 2000 or 1800 or 1500, etc., is because this is age dependent. Okay, this is the first most important information that you need. If you're doing a neonate and you and you put 1500 milliseconds, you will not get anything, or you will not get good images. So PLD is age dependent, and I'm not going through the physics behind this because that has already been taken care of by others. Numbers. Now, this is a set of images, as you can see. Give me a second. Yeah. So these are a set of images that I've brought to you. As you can see, CBF or ASL maps in neonates is dark. And it's dark not because there is no perfusion, but because a neonate doesn't have that kind of vessel density as a 1-year, 7-year, 15-year-old has. So this brain is developing, and therefore the vasculature and the cerebral the tissue perfusion is changing and growing as well. All right, and this is the reason why you need to adjust your PLDs. You have some numbers here, and this was also discussed earlier. Of course, this is global CBF. It will change with the gray matter and white matter and in the basal ganglia. This is a very old image, and I just brought it for the sake of you guys looking at them. As you can see, number one, what I see in this image is I can see the anatomy, all right? So an ASL will show you a good anatomy. You can see the cortex, you can get a sense of where the white matter is, you can see the ventricles, where you can actually kind of, you know, you can a little bit of intuition, and you know that the anatomy is visible on your ASL map. This is an adolescent, and you can see there's a lot more yellow colored, like a lot of perfusion right on the top of this color bar that is happening in the gray matter. This is really, really bright, and it's normal for an 11-year-old, 12-year-old. This is actually a paper coming from our own Iris Aslani's group, where they started to look at the differences of ASL with age. And you can see in the graph again here that the global CBF in a neonate is pretty low, and it increases normally with age, and then it plateaus off to a more of a healthy adult perfusion level. There are a lot of factors that will change your CBF. Be mindful of this before you think of, oops, this is disease. You need to know that there is, and you already know it, that there is an autoregulation in the brain. That is making sure your CBF is always in the same normal, healthy range. The cerebral perfusion pressure, and in the next slide, I'll show you what I mean by that. The level of CO2, if a patient is breathing heavily, perfusion may change, okay? The oxygen reactivity, temperature, blood viscosity, you might have cases of anemia, right? And those things are going to change. A patient is dehydrated, okay? The activity of your autonomous nervous system, sympathetic versus parasympathetic. Patient is really anxious, and he's in the scanner, lying down, very worried, really fearful, and you see changes in perfusion. That is related to his stress rather than to a normal, healthy, to disease-related perfusion, for example. Blood pressure, and then again, endothelial coupling, NV coupling, all of this becomes very useful in the in the more advanced ASL techniques that Danny talked to you about earlier. And then, of course, if you have a healthy adult, if you have an adult with all kinds of atherosclerotic risk factors, for example, you don't know, but the patient has carotid stenosis, You can put your PLD to 1500 to 1800, but the blood is going to flow in slowly because the person has stenosis that you don't know of, right? So it can get complicated. I don't want to make and tell you that it is complicated and, you know, scare you away from this, but just be mindful that all of this is happening to determine perfusion. Now, in the literature, ASL has been applied in pretty much all kinds of diseases, all right? Oh, by the way, I've put this, I got this in Tanzania, and just so you know, this Africa is with me. All right, so in the pediatric population as well, there are several diseases where ASL can be applied, okay? So of course, stroke, you can use it in vascular diseases, all kind of malformations, tumors, okay? Tumors, mostly I would say follow-up, epilepsy, cerebral palsy, TBI, etc. Okay. The interesting thing is that ASL is giving you one more information. If that information is helpful to make a diagnosis, do it. Okay. We usually just do structural images, T1, T2 flare, DY, and a gradient or an SWI image, and that's it. That is fine. But if you can insert a perfusion image with no cost, right, then why not? That is the idea, at least in a clinical setting. Research is a completely different scenario. Okay. That's all to do with, okay, hold on. Why don't I have a, why am I missing? Give me 1 second. Give me 1 second. I really wanted to show you a slide, which for some reason I don't have it. Okay, I don't have that slide, but we can go through this during the masterclass. Let's go ahead in the sake of time right now. Let's just look at some images. Relax, don't take a lot of notes, just look at these images. This is a case of a 12-year-old with trauma. Okay, she hit her head, it's chronic trauma, it's 4 months already, and we did a follow-up. You look at the structural images, that is the best you can do. Most of the MR scanners, even if you don't have an ASL, you do this, right? You may not do the DTI colored map, but you do this and, you know, you can do the diagnosis. This is a Malaysian temporal lobe, frontotemporal area. There is a ventricular enlargement here. There's loss of white matter in the left hemisphere, and this will be correlated to the clinical aspect. That's fine. If I add a DTI, I can also now confirm, you know, yes, the fibers have been lost. Okay, there's an information that is being given. If I do an ASL, all right, I'm getting one more information, which may be of use to clinicians, and that is that area, even beyond the area of trauma, is hypoperfused. So that is a kind of information that new information that a clinician may obtain to understand why this patient has, you know, some symptoms that are not related to this area of the brain, because there's hyperperfusion in the parietal occipital area as well. Okay, same patient, you go down to the cerebellar area, and you look at these images again, and you say, well, yes, there is some trauma happening, and you know, trauma in the temporal lobe as well, ventricular enlargement. Cerebellum is pretty normal. Is that true? I wish I was there to see your faces, but the cerebellum looks good. Yeah. But when you do an ASL, now it hits you that yes, there is low perfusion where the injury is. Yes, there is good perfusion in the opposite temporal lobe, but why is there low perfusion in the cerebellum, in the contralateral cerebellum? So that is this is the concept of cerebellar dyschisis, okay? If there is a damage on the right hemisphere, the left cerebellar hemisphere may also be damaged or may have low perfusion because they are connected. And this is important because this is one of the prognostic markers of, well, one of the markers of bad prognosis, for example. Right. And again, the other information that you're getting here is that there is widespread white matter hypoperfusion as well. So see how much information we have now been able to give, excuse me, to our doctors, to our neurologists or child or pediatricians. 7-month-old left ischemic infarct. You can see it. You can see the ischemia. You can see the vessels are lost. You can see that there is loss of tissue, white and gray matter. That's it. What else do we need to tell in this patient? If you add a perfusion ASL, you might get some more information, and that is pretty much the area here. You see that there is loss of perfusion in the white matter, but the cortex seems to be almost doing okay. Okay, there isn't this large area of hypoperfusion in the cortex, which is good. It's a good sign, and yeah, and as you can see again, you already talked about this. The posterior has a good perfusion, and that is most likely because of robust posterior circulation, but also because of flow dynamics that are different in the posterior arteries with respect to anterior arteries. This is a case of, if you look at this image right here, it's a T2 coronal image. And you can see this little AVM hanging down, right? This little thing. So this is this child, 15-year-old, he had a large AVM and we saw him only after surgical removal. And the doctor said that he has a little bit of AVM still remaining in his brain. And so can you scan and see if it's going all well? So I see that AVM, right? I can give a contrast, I can give gadolinium, and I did. I will tell you why. Why do I need gadolinium in this? Because I need to know if this AVM is connected to the main circulation or if it is closed, right? That is the only reason why we're really doing a gadolinium in a post-surgical malformation. So I see this. I've done a DTI and you can see so many fibers have been lost because of the surgical intervention. And then there is the ASL. Now, if you can see, look at this properly. So there is all of this dark area where there is low perfusion. That's okay. The gray matter is gone. Yes, we see that. But we see this little blob here. See this? Okay, so this is your AVM. And there is flow in this AVM. So that's your AVMs right here in the subarachnoid space. Look at this. These are your AVM blobs. I did I overlapped a structural image and the ASL map, and you can see that they are exactly where the AVM is. And this is your dark CBF image map as well, where you can see this little loss of signal, which is right where the AVM is. So there is flow inside this. Why we are giving gadolinium? We can avoid gadolinium, but there are no true recommendations that we are allowed to do so. So there is enough evidence to say that you can follow up AVMs without giving gadolinium, and you can do ASL. But in your initial cases, you should be giving gadolinium. So be mindful of the thing that ASL, unfortunately, hasn't replaced gadolinium-based imaging for good as we speak today. This is another case of a child with what we call a Sturge-Weber malformation. And there's a big angioma in this part of the brain. You can see that in your SWI. The vessels are also a little scarce. And this is the ASL. All right. Actually, before even giving the ASL image, I should have given you the gadolinium-based image, where you can see that the gadolinium is in the angioma, which is on the pile surface, on the surface of the cortex. See that? And these are 3 different images. You have the black blood. You see this completely dark. You see the T1 empurage. It's filling up all the little veins and angiomas. This is a post-contrast flare, right? We did not do the typical perfusion weighted imaging based on gadolinium, which is your dynamic susceptibility contrast, or a T1 based DCE. We did an ASL and we found a global hypoperfused right hemisphere. And this is good enough for me, and I don't have to do a DSC, tissue perfusion, gadolinium-based tissue perfusion imaging. Okay. This is the same subject, and very curiously, this patient has a has a lot of perfusion in the temporal lobe with respect to the contralateral. This is very tricky. We can go through this again during the masterclass. So this is the patient, right? No perfusion, hypoperfusion in the right hemisphere where the angioma is. Great. I go down to the infratentorial and it's flipped. Why is it flipped? Now, most likely this thing is because of how the arteries are. If you notice, the posterior cerebral artery in the right hemisphere is coming from the anterior circulation from the carotids, whereas the posterior cerebral artery in the left hemisphere has a normal origin from the posterior circulation. And this may be affecting the level of perfusion in the right and the left temporal lobes. And it's not because there is an angioma in the left temporal lobe. Okay? So very, very careful of how we interpret images. A simple case, again, cerebral palsy, 9-year-old female. You look at these images and you make the diagnosis. Patient definitely has all the clinical symptoms of cerebral palsy. So you can see a lot of damage in the white matter, right? There's a lot of ADC signal, high signal in the white matter, which means that there is gliosis, right? And a perfusion ASL, if you have those 4 minutes, if you have the sequence, it's going to just confirm that yes, there is loss of perfusion in the white matter, but there's also some perfusion loss in the motor cortex, and we know cerebral palsy affects motor areas. This is a mutation, genetic mutation, patient with what we call CACNA1A. It's a voltage-gated calcium channel for water metabolism, and there are infarcts in this patient. This patient will have infarcts, and you can see there is more of a global hypoperfusion in the right hemisphere, even though some of the areas have infarction and some others don't. Okay? And of course, DTI is showing you that there is loss of fibers. Yes, so same subject, one level down. Again, you see how globally affected this child's perfusion is in the right hemisphere. AV fistula, okay? You don't have contrast in this case. For example, you don't have gadolinium, and you see all these black dark voids. This is flow void, right? So, but this could be artery, this could be a vein. So you do a TOF, TOF, time of flight sequence, and they're not lighting up. So these are most likely venous. You do the ASL and you can see them lightening up. And guess what? There is this, and in fact, there was a little fistula on the other side as well. So just an image, a sequence, an ASL that shows and confirms that these are vessels and there is flow in them, and they're most likely at this point venous with high flow, because this is a high flow AV fistula. Post-hemorrhage, no need to do an ASL on an 8-year-old post-hemorrhage, really. But again, you see this vast, devastating porencephalic cyst. This patient has scarce arteries, very, very poor perfusion, almost all gone. So this is pretty much dead tissue in the brain, and it's going all the way back to the occipital area. Moyamoya syndrome. Now, this is not the best case I have for you. We don't get a lot of Moyamoya syndrome. This is the only one I have. But literature suggests that in Moyamoya syndrome, ASL can give you very good information. This is our own case. As I said, there is some, there are some vessels right here that are altered. This is your contrast enhanced imaging. But here you can't see anything. And this is likely because of flow dynamics and that ASL cannot really pick it up. And I'm not sure if I had at that moment the right PLD. And so we could not pick up this information, but it doesn't matter. So these are the cases. Now, I also want to tell you, and this is one of the big projects that I'm trying to do in my own institute, and it is the possible effect of sedation. When you're doing children, unless it's a neonate under 6 months, where you can try the feed and swaddle technique, you need to sedate these kids. And if you sedate them, you understand that you're reducing the perfusion. Now, we don't really know how much perfusion is reduced or not reduced or increased with different types of sedative drugs. There is no information, or there is very little information or current literature on this. There is some information, but not much, especially in kids that are younger than 5 years. And so you just need to know need to remember how to interpret this kind of image. What I'm showing you here is pretty unique in the sense that this child was sedated. We were doing the sequences, we did our ASL, and then he woke up. Okay, the effect of sedation went away. And so this is his ASL just when he woke up. And so because we were not sure if this came out well, we sedated the patient because he still had to finish his diagnostic scan. He was sedated, and after the bolus, we did another ASL, the same sequence. And so you can see the big difference that there is, and we have no idea if this is artifactual or if this is the effect of sedation, which is reduction of global perfusion. Okay. All right, I'm going to go over this during the, so we had, okay, here. Now, big question, big question. We are all excited about ASL, and it's correct to be excited about ASL because we want to reduce gadolinium globally, not just in children, but also in adults, right? Are we ready to replace it? Now, if you are a neuroradiologist, you know that if you're looking at this image, this is not a perfusion-based gadolinium image, mind you, okay? But if you're looking at this image, you can say that this patient has meningioma. You don't need histology for this. It's extracranial, it's well demarcated, there is sunburst appearance. This is meningioma. This is not glioblastoma, this is not lymphoma, or at least 99% it's a meningioma, correct? But if I do an ASL and I get this, what I'm doing here is there's a hyperperfused solid mass, but I don't know what it is, right? So you can't replace gadolinium completely, not yet. Every effort is being made to do that, but not yet. That's my personal opinion that I would like to transmit to you all today. You can think of doing this as follow-up. So you get this tumor out from the surgeons. Surgeons say, do it again, see if there is some more tumor in there. If it's growing, you can try and do an ASL. You can follow it up. It's a small meningioma. You don't have to do every year gadolinium-based imaging to understand if this is growing. You already know it's there. You can do an ASL. You don't have to do any kind of differential. So be mindful of when you need one or the other sequence. This is an image coming from literature. For example, there is a lot of push towards doing ASL during follow-up after therapy. Okay, so if you've done post-radiation, you can see if the ASL is telling you something regarding perfusion in that area. But as again, there are no recommendations, national or international, that suggest that you can completely replace ASL. In many diseases. This is an example of ASL in migraine. Now, if a person comes with migraine, most of the times you will get a normal brain MR. Okay, there might be some bright spots, but it's a normal brain. Now, this is a very good case because if this patient has a lot of migraine, if he has aura and it's happening during the scanner or just, you can do an ASL. You don't have to give gadolinium. You do an ASL and see if there are changes in perfusion. And this is a case of hyperperfusion in the occipital area in a patient with migraine and visual aura. So this is a good example of where you can avoid contrast, and contrast may actually not help at all. And by the way, I would insist when I'm saying gadolinium-based imaging, I'm talking about perfusion-based gadolinium imaging, which means you need additional injectors, you need, of course, gadolinium. It is a more expensive setup. Okay, so yes, everything is going towards ASL, but again, you can't replace it 100%. This is a very good example of a subject with brain death. Okay, so this is enough to suggest that this is brain death. There is EEG, there is patient clinical symptoms. You can see that this cortex is all swollen up, etc. When you do perfusion, you see that this brain doesn't have any perfusion left. And the only perfusion that there is from the extracranial carotid artery. So again, it's a good example of when you can try not to do contrast and get just more information. Now, it's a T1 based image, remember? So please don't do ASL after you've given gadolinium, because that is going to change the T1 values of blood. And of course, you may not get the kind of perfusion, the normal perfusion after you've given gadolinium. So you will be doing it before giving gadolinium. So again, my talk was about clinical indications, and I would say that be curious that one center that has ASL and the others who want to get ASL should try and get the ASL sequence on their scanners, and should be curious and try these sequence out in all kind of diseases. Tumors, I would suggest you do it, but then it's more important in the follow-up. Malformations, again, more important in follow-up. Multiple sclerosis and others, follow-up. Genetic diseases, you might get more information. You know, hey, what does the perfusion look like? Do an ASL. Epilepsy can be a good one, like the medial temporal sclerosis. Well, a child, adolescent may have some. So if you don't have a pet, you can do ASL to see if there is dead tissue. Infections. Infections could be a very good one. So all kind of bacterial and viral infections, that is a very good application actually for ASL. I should have shown you some more cases on this. So again, infections is good. Remember that ASL cannot see leptomeningeal contrast enhancement. It will see tissue information, but not what is happening outside the brain. So meningitis, you can't do it with ASL. You can do abscesses, you can do viral infections, you can do encephalitis, right? So that's a good one. And as I said, it's an easy add-on to standard clinical protocols. It is getting more and more advanced. We had to buy the sequence now because it was optional. Now the vendors are actually giving it for free, like it's part of the standard protocol. So it has a lot of advantage. And then coming back to this slide again, this was a debate we had in European MRM Society in 2022, and I was asked to be for gadolinium-based imaging, and my opponent, my colleague, he was talking about pro ASL. So we were all very aggressive, both of us. I was like, ASL is dead, gadolinium is the best, blah, blah, blah. And the other guy, he was like, ASL can do everything and we don't need gadolinium anymore. At the end of the debate, we both held our hands, shook our hands and said, you know what? I said ASL is not wishful thinking. ASL has a lot of scope, and he understood that gadolinium still needs to be is needed, but we can reduce that. Thank you for your attention. I'm happy to take questions, and again, I will do all of this during the masterclass as well.
All right, thank you so very much. I'm happy that our children are not left behind in making this diagnosis using ASL. So we take a few questions. If you have a question, please show by the raise of hand. She's online, so she needs to answer the question while she's there right away. Okay, that's one. Take your number one. Any other person? All right. Please, let's give him the mic. And those online too, you can raise your hand if you have questions.
Right.
Go ahead. Yeah.
Thank you very much for the presentation. Coming from a radiographer's perspective, and also probably also related to, I would like to know, given that we are dealing with pediatrics and neonates and all, in terms of practical challenges or considerations for signal to noise, do you really get noisy maybe maps because they are pediatrics, or does it really play a factor at all, if I could ask? And how do you overcome such challenges, if there be?
Yeah, well, thank you for that question. That really should be for my engineers. We haven't seen a lot of trouble with noise. So the first time I started this, yes, there was trouble. We were not getting good information from neonates. And that is when we understood and we learned that PLD was important. But for now, we're not getting any kind of disturbance with background noise at all. Of course, remember that if the patient has artifacts, it could be because of metal. There's a lot of other things that ASL can be affected by, right? But no, I don't see any, not seeing any background noise right now.
Thank you very much. We'll just give the next slot to anybody online. Is there anybody online? Okay, if there is no one, we allow the Professor Ogbole to ask his question.
Yeah, thank you for that brilliant lecture. One of the things you mentioned at the beginning of your lecture was the parameters that could affect, the ASL maps that we get. Things like, of course, oxygen, and other parameters. Are there ways of checking for these parameters to ensure that you have the value you get are standardized or are reflective of the current condition of the patient? Are there ways of checking for the oxygen flow and things like that? The other question I want to ask is that do you have a separate panel or like a workstation to do post-processing for these images, or do they come off the system automatically? Is there auto processing on the system for you to be able to read the maps, subjectively, or do you have to do post-processing and do quantitative analysis after the subjective qualitative imaging analysis?
Right. Okay, so two questions. Yeah, no problem. So you asked two questions. So number one is the parameters. Now in our sedation group, okay, so children and adults, if I'm sedating my children, they're always monitored, right? For the basic parameters of heart rate, CO2 levels, they're always monitored. Number one. And even in adults, remember that there is an important cerebral autoregulation happening. So usually a normal subject, I don't have to check for oxygen and CO2 levels in their brain. Okay, it's going to be normal in that big 50 to 150 mm of mercury range, and there is no problem with perfusion. But it might become important in certain extreme cases. So patient has respiratory difficulties, patient is coming from the ICU, right? Patient has a cardiac function or cardiac malformation. You need, then that is when you look at the CBF map and then you're looking at the interpretation, says, I don't understand why there is this changes. It might be because of the cardiac defect, or because he has dyspnea or some other disease that might be affecting. So it's just a consideration. It's not sustainable to actually get all of these parameters in a subject who may or may not be doing an ASL. That's how we do it. The second question was about post-processing. And so the scanner that we have, and I guess all the scanners, they will give you a first initial CBF clinical value map. Okay. And remember that these are going to be the FDA approved. So I can make a diagnosis on that map rather than what is coming out of a MATLAB post-processing map. So that's a good, important reminder to everyone, because legally, what you quantify should come from what has been considered, standard practice. Okay, we do have, for clinical purposes, a post-processing algorithm, let's say, and we can quantify using that. But once it goes to our engineers and they give me a number, I don't use that for clinical purposes. I use that only for research purposes. Does that make sense?
Okay, can I go ahead?
Yes, thank you.
Okay, sorry. Yes, thank you, Prof, for that question, sir, because that was in the line of my thought as well. But I just want to make a clarification. Thank you, Nivedita, for the very loaded lecture as usual. But I was wondering if our control images can play any role in checking for these parameters, because I was thinking that the control images can help us to compare what we had before and then what we have after applying the Spain labeling. So do the control images have any impact in checking for this?
Well, okay, so this is for me, it's a difficult question, but what I use control is only to check for any kind of motion artifact or something. If that has, if the subtraction hasn't gone to it hasn't been a good one. Other than that, I think it's more of a question. I haven't had a problem or a reason to check my control images other than the fact that, a good subtraction hasn't happened. Maybe Danny can help you with that.
Yeah, sometimes I think this is something still need to push the vendor to. I think the sequence now is getting standardized with the 3D pickup, but the post-processing, each different vendor, they give you different color scale. Some give you scale. I think at the United, we tried it in Radia. They give you a color map. They don't give you the scale. It's a little hard to read. I know Siemens has a very arbitrary scale. GE is the most standardized. Yeah, so I think there's still, although they're all FDA approved, but there's still difficulty to interpret, I think. Yeah, I think we should talk to this industry to standardize this. Yeah.
All right, let's put our hands together for her. Thank you so very much. So it was a wonderful time.
Thank you.
And we hope you'll still be online with us to share the moments and the day with us. Thank you. All right, we're moving straight away to the next lecture, quantification in ASL, measuring cerebral blood accurately. And to take us on that, we have Benjamin Aribisala. Please, you're welcome to take the lecture. Is he online? Is it there? Okay, we take our break. Okay. All right, all right then. We expected Benjamin Arubisala to join us virtually, but since he's not there, we'll take a short tea break and then we come back and cruise ahead for the rest of the day. All right, so 20 minutes as ordered by our ushers, we go from row to row to have a tea break. Enjoy yourself.
Only you the best thing for me, yo. I know nobody matter more. Nobody matter. Nobody matter. Feel like I don't win a lotto. I know if we pull it down more. Pull it down. I'm risky, on holiday to Mozambique. Follow me go to Mozambique. Baby girl, are you on your way? She made the bring girl the drop that. Oh, then you know be like I do overdo. But we don't go trouble your time. Like, get there, baby, go. Don't bother, man, make that fight one Lord. Trouble your time. Like, get there, baby, go. Stop for them and have my Baby girl, oh, you look at me. Now I so look at you. You be tight now, why? You be tight now, why? Baby girl, oh, you look at me. And now I so look at you. You be tight now, why? You be tight now, why? Live boy. Hey, oh yeah, point and take. Put it all on. My own baby. Put that for the paper. 25 good, 25 good. Babylon one. My own baby. Put that for the paper. I'm risky, on holiday, holiday to Mozambique. Follow me go to Mozambique. Let the girl are you on your way? She made a bring helicopter. Then na, make you look like I do about to. But I don't trouble their time. Keep them in the corner. Trouble them and I want. Make that by one trouble their time. Keep them in the corner. Trouble them and I want. Make that by. Every girl look at me. And I want to look at you. It's tight now, why? Put it tight now, why? Every girl look at me. And I want to look at you. Keep it tight now, why? Keep it tight now, why? Bye, boy. Hey.
Mr. Bombastic, Mr. Romantic, Mr. Fantastic.
Nothing is carved in stone. You know the night is young. I'm feeling good, I'm in my zone. Brought me a fat big blonde. And now them taba wallet. I'm burning in my life to wallet. Do it like what? Cause I'm a good love. I be shame me can't stop. I'm so fly, my God. Mr. Bombastic, Mr. Romantic. African boy with the do magic. Give me the punch left in the Lambo. Manga boy, everybody want blue. Bounce down, I know that body that boy. My love, I'm a time, I be, I know. I'm gonna lay what you. And you go lose control. But your knees not your toes. Give you the bad man love. I'm gonna lay what you. And you go lose control. But your knees not your toes. Give you the bad man love. I'ma look out to Dubai. She niggas spend with the time. When you didn't make you guy. Going to the left and right, baby guy. Guy. No killing person, baby guy. Kilo one day, go by. Baby guy. Guy. It's too easy cause the money surplus. The money don't stop a long talk, long talk. How many things you won't count? You better relate with your mind. I see the vibe they do me. Not gonna use your own, gonna confuse me. Yeah, I did not see they do me. Hot box pass, baby, for me, for me. Diamonds every new way. If there's something that you wanna do, do it. Oh, wale, mo me. Men de physically fit, wale, mo me. Oh, bella, po me. Ọmọ wa bá mi jò, ọmọ Casamigos. Wọlé ìwájú, you go lose control. Your knees touch your toes. Give you the bad man love. Wọlé ìwájú, you go lose control. Your knees touch your toes. Give you the bad man love. I'ma look for to Dubai. She make you spend with the time. When you didn't make you guy. Going to the left and right, baby guy. Guy. No killing person, baby guy. Kilo one day, go by. Baby guy. Guy.
Yeah, Mr. Bombastic, Mr. Romantic, Mr. Fantastic, Yabayastic.
First, let me say to you, I can't wait to see you. You are the treasure I've been waiting for. Do you know how much I really need you? I dey pray for the day when I can finally kiss you. You know, say every day I dey pray for you. Oh, in my heart today is the permanent place for you. That's why my heart it a beat like you. But now you are too so I know. I sing for you wanna be like you. Baby, now you are go be boy. What baby, oh. See, I may not give the world to you, but I'll give you what I have. Oh. Baby, oh, you are my angel. Oh, do you like me? Oh, should you not there every day I pray for you? Oh, in my heart, oh, there's a permanent place for you. That's why my heart is a beat like you. But now you are too so high for me. I sing for you wanna be like you. Baby, now you are go be me. Only for you it'll be like I sing for you, my baby. Do do I love baby. I love daddy. Oh, you baby. See me now.
The lectures are resuming in 5 minutes. Please find your way back to the hall. Thank you.
Who could believe you? The whole world is calling you like. Love me, I go love. I go love us, people love. No good to live your life to impress anybody. Cause some people was past the time. I go love me, I go love. I go love us, people love. Even though you love everybody no go be love you. But my mind to my weapon. Look the world with the lights gone down. Anytime you beg someone, I go like when you hear this song. Me and you love you, Jesus. So now only you love us, we will love. So now only you love us, we will love. Let me say, but focus on your bread butter. Features and butter. Make sure that your mother knows about. Just to live your life, Baba. Just keep them real and proper. Focus on better customers. The Niger, no, brother. Search you will find. You know my time, they're close to you. Never buy a dream if it's so to you. You'll be by your side if you are true fire. Although you standing steady fire. You don't love me, I don't love.
For those online, please grab your cup of coffee.
The whole world is calling you like. You don't love me, I don't love. You don't love us, we don't love.
We're starting. Okay. Please, if you are still around the corridor, please come into the hall right away. We're starting and we're continuing while we still gulp down our coffee and listen to the lectures at the same time.
Competition for my lady. Oh, no. But she got everything when I need in a woman and more. My lady, if you see my lady, oh, it's not for one. You go know say people fine. You go know say God design in a LLA. Oh, na LLA. Oh, she na ya show. He like my dress. She na face so. He like her dress. I say nobody be contest you, my baby. She na ya show, she na face so, she na waist so, I don't be beto. Nobody be contest you.
Please, let's find our way back to the hall.
Mama be, daddy, come on in, like you have a show me what you got in. Good baby, Ulada, good baby. Àmì mọ́ra Angelina Jolie, ìwọ nìkan ò ti tó mi. Mo kọ́ ẹ̀jẹ̀ bíi ti Indomie, bébí dúró mọ́ mi, no go leave me lonely. Gbàgbé Johnson, make you leave the story. Má lọ para mọ́ mi, cause she still sọ mi. Ìwọ ṣáà máa wò mí, bí mo ṣe ń jó ìwọ ṣáà máa wò mí. Ó ní problem ìwọ lálábàárò mi. Ọlọ́ládé okòrí mi má dàpọ̀ mi. My soul, my soul, you be melody for my soul, girl, you're my own. I need you around. Competition for my lady. Oh, no. But she got everything when I need in a woman and more. My lady, if you see my lady, oh, it's not for wrong. You go know say people fine. You go know say God design in a LLA. Oh, she na ya show. You like my dress. She na face so. You like her dress. I say nobody be contest you, my baby. She na show, she na face. I must tell my mommy for you.
All right, yeah, all welcome back from that short break. There's no crime. You can still continue the good work while you learn. So the next speaker I'm going to be calling up now, we missed our lectures yesterday, so we give her another opportunity so we don't miss out on the knowledge. Ladies and gentlemen, we're going to be listening to an overview of clinical application of MRI, and that will be delivered by no other person than Dr. Ifeoma Nuru-Abasi. Let's put our hands together for her, or just tap your table if you're busy. You're welcome to the podium, please.
Good morning, everyone. My name is Dr. Ifeoma Nuru-Abasi. I am a fellow of the West Africa College of Surgeons, a radiologist, and I work at University of Nigeria Teaching Hospital, Enugu. I also have MSc from the prestigious University of Queensland, Australia. It's a great pleasure for me to be here today to speak to you on clinical applications of MRI. I know that we've listened to a lot of experts talking to us about new innovations and a lot of techniques that we are not yet doing here. But I want us to also look at what we do here and then some of the other techniques that I found really interesting during my research for this presentation. Thank you. Okay, so this is an overview of my outline. So we'll be looking at MRI in neurology, cardiology, musculoskeletal imaging, oncology, abdominal and pelvic imaging, breast imaging, and then some new recent innovations or emerging techniques and future directions. But then I'll be looking more at neuroradiology and musculoskeletal imaging and breast imaging for want of time. Thank you. Okay, so this is an overview. I just want us to remember what we're here about MRI, and that's a scanner with some of the components of the scanner, the magnet, the RF transmitter, and receiver coil, the gradient coils, and shim coils. We know all of that, the components of MRI. Okay. So magnetic resonance imaging, as we all know, is a non-invasive imaging technique that uses strong magnetic field and radio waves to generate detailed image of the body internal structures. Okay, this technique leverages on the fact that the body is made up of mainly hydrogen protons. There are other protons, but then MRI is all about the hydrogen protons, which has the ability to spin when RF, radio frequency pulse, is introduced. Okay, then when it's introduced, the hydrogen atoms spin, and then there is transverse magnetization and loss of longitudinal magnetization. And then we have the free induction decay. We have our images, T2 star effect, and then for the normal spin echo sequence, you keep introducing 180 RF pulse, and then you acquire your images. Okay, just a reminder. Okay, so what are the advantages of MRI? It has an excellent soft tissue contrast, is non-ionizing radiation. It has an ability to give us multi-planar imaging capability, functional and anatomical information. And then we also have to remember that there are safety considerations when we're talking about MRI. Remember that when the patient has ferromagnetic components in the body, MRI, because of the force, the magnetic field, force of the magnetic field, it's possible to dislodge some implants or move ferromagnetic objects like wheelchairs or cylinder or whatever. So we have to remember that safety is very important. Remember also the gradient, change of gradient curves that can give you noise, or radio frequency pulse that can cause heating in MRI. So it's very important to have a checklist and where you have to rule out the electronic devices or other potential hazards. MRI in neurology, MRI is the primary tool for neurological imaging. It's also the gold standard for brain and spinal cord imaging. It's able to detect structural and functional abnormalities. So pathologies like stroke, where you have the diffusion-weighted imaging that you can use to detect acute stroke, identifies ischemic and hemorrhagic stroke. MRI, diffusion-weighted imaging, has the ability to detect strokes within minutes of onset, multiple sclerosis, brain tumors. And I wanted to go into FLAIR, but for want of time, I'm not going to go into the physics of FLAIR. But FLAIR image is used to suppress signal from fluid, especially the cerebrospinal fluid. So cerebrospinal fluid is null in FLAIR images. So this now gives the ability for other lesions in the brain to stand out. When you null fluid from the cerebrospinal, null the intensity or signal intensity from cerebrospinal fluid. Okay, so what does a FLAIR image look like? A T2 FLAIR image. Cerebrospinal fluid is going to appear dark. Gray matter will appear intermediate to bright on T2 FLAIR. White matter appears intermediate to dark. Ligaments will appear hypointense. Then what it means is that edema will now stand out to appear hyperintense, okay, due to increase in the water content. These are some of the pathologies that you can diagnose using FLAIR imaging. Multiple sclerosis will appear as hyperintense lesions, and these are plaques, as we know, within the brain's white matter or spinal cord in multiple sclerosis patients. Cerebral infarction in the acute phase of ischemic stroke will also appear bright, hyperintense. Brain and spinal cord tumors, normal pressure, hydrocephalus, abscess and inflammation. Abscesses would also give hyperintensity in FLAIR images. Okay. So more images. You can see T2 FLAIR in acute ischemic stroke, in brain hemorrhage, multiple sclerosis. You can see the hyperintensities within the white matter at the cortical medullary junction. And then spinal cord injury, which appears hyperintense within the region of the spinal cord. Then we'll move over to diffusion-weighted images. Okay, diffusion-weighted imaging MRI provides contrast that depends on random Brownian motion of water protons. And these are used to diagnose, that is to say that in areas where you have hypercellularity, diffusion-weighted imaging would appear bright. Okay. ADC always comes with the diffusion-weighted imaging, and this is the apparent diffusion coefficient map. Okay. It showcases the pace at which these molecules disperse and transfer within the tissue. The movement of the water molecules is impacted by factors such as cell density, cellular obstacles, and tissue microstructure. There are values of this ADC, which we call B value. So first of all, you have to acquire the baseline image, which will give a B value of 0, and then you can have a B value of 1,000, 2,000, depending. So the higher this B value, the more sensitive it is for you to detect these pathologies. Okay, this shows the baseline image that is acquired, which usually is like a T2 weighted image. And we give it a B value of 0. And then the next one is a B value of 1,000, and then the ADC map. So you can see in the B value of 1,000 that cerebrospinal fluid appears dark. So while in the ADC map, it's hyperintense. Pathological appearances in diffusion-weighted MRI images. So these are some of the pathologies we can detect using diffusion-weighted imaging. Acute ischemic stroke due to cellular swelling and decreased movement of water molecules will show restricted diffusion and thus appear hyperintense. Brain abscess, the center of the abscess will typically have high viscosity of pus, and this will also appear hyperintense. The surrounding edema might also show some increased signal due to disruption in tissue microstructure. Brain tumors with high cellularity, such as gliomas, will also show restricted diffusion and will appear hyperintense. Multiple sclerosis, due to the inflammation and demyelination in the CNS, can show varying appearances in diffusion-weighted imaging. Active lesions will show restricted diffusion. acute trauma in cases of traumatic brain injury, such as contusions or hemorrhages due to disrupted tissue integrity, will also show restricted diffusion. And all of these will give hyper intensity on diffusion weighted imaging. Lymphomas and metastases will also show hyper intensity. Okay, so these are examples. You can see the glioma right here. Okay, showing that hyper intensity, lymphomas, and acute stroke. All of these, ovarian cancer, these will show as hyper intensity. Dynamic contrast enhanced MRI is a technique that involves acquiring a series of MRI images in rapid succession after injection of contrast. Okay, we've talked so much about that. We've compared it with ASL. So there's no point overflogging this particular sequence, but you have to take note of key concepts, which include washing and washout. Washing is the initial rapid increase in signal intensity after you have injected contrast, and the subsequent decrease is called the washout. Then there is a pharmacokinetic modeling, okay, where you have parameters like the K-trans, which is volume transfer constant, and rate constant or extracellular volume fraction. So there are, MRI has a lot of application in oncology. Oncology is nowadays, even in our own environment, we have a lot of cancer cases. So MRI is very important in diagnosis of and in cancer management for tumor detection, for staging, monitoring, whole body imaging to check for metastases, tumor detection and staging. MRI is able to differentiate between benign and malignant lesions, access tumor size or spread. And for treatment follow-up, unlike other imaging techniques that uses ionizing radiation, so MRI is a very good tool for follow-up after treatment. Okay, so for musculoskeletal imaging, MRI is very crucial in characterizing musculoskeletal tumors, assessing treatment response, and evaluating inflammatory processes. Breast imaging. MRI is increasingly becoming the modality of choice for some indications, which I'm going to talk about soon. MRI is the most sensitive and advanced imaging technique in diagnosing breast cancer. It is essential in cancer detection, lesion characterization, and determining therapy response. You have the protocol, which includes T1 weighted image, which is used to plan, to localize, okay? And then you have the dynamic T1 fat saturated gradient echo before the gadolinium injection. Then the T2 weighted and STER sequences, also diffusion weighted and dynamic contrast imaging techniques. What are the indications for breast MRI? Screening in high risk patients who have a family history of cancer of the breast. So MRI will be very good, especially for women who are younger, below the age of 40 or much younger. It's also a supplementary screening tool in average risk patients. It's used for occult breast cancer detection, investigation of nipple discharge, implant assessment, this age and time where women are enhancing their body, putting silicone and all of that. MRI is a perfect imaging modality for breast implant assessment. To evaluate response to new adjuvant chemotherapy for staging for women who have very dense breasts and they are above 40. MRI is good for visualization. Palpable mass with a negative mammography or sonography. So when a patient has clinical symptoms of breast cancer, but then mammography and sonography is not helping. MRI is the go-to modality. Axillary lymph node metastasis with unknown primary, unexplained swollen breast or breast implant. To check the extent of infiltrating lobular or ductal carcinoma, to check for residual disease, post-lumpectomy, post-operative tissue reconstruction. Nowadays, we're having a lot of breast reconstructive surgeries. Okay, so MRI is a good modality for MRI-guided biopsies, for surveillance. We already talked about that, to know the extent of disease, recurrence of breast cancer, and lesion characterization. So I came across this diffusion weighted MRI, which they call the Zoomit for breast imaging. Okay, it's an advanced MRI imaging technique that leverages is from Siemens, and it introduces a new platform with two independent transmitters. Okay, it utilizes the concept of zooming in MRI imaging. So what it does is that it offers several advantages over conventional diffusion-weighted imaging techniques. It employs multiple parallel radio frequency pulses simultaneously, capturing high signals, specifically from areas of interest. This particular approach reduces folding artifacts, provides better anatomical detail, decreases distortion and blurring, and then it improves overall image quality. Additionally, it's faster, it has increased spatial resolution, and minimizes susceptibility artifacts. Okay, so these are images from Zoomit sequence. So the first one is a T2 weighted image, and you can see the left breast showing a very well-defined ovoid mass lesion that is hyper intense and some considerable edema. And then the second image is showing vascular, is a maximum intensity projection of dynamic series, showing dramatic increase in blood flow to the entire left breast. Okay, so this alone will tell you that it's not a benign. It gives you an idea that whatever is going on there is malignant. Okay, and then you have the color flow map showing the central area of necrosis and the red malignant washout, which shows peripheral enhancement. Okay, these other images with the arrows are showing lymphadenopathy, enlarged lymph nodes. Okay, internal mammary lymph nodes, and here axillary lymph adenopathy, level 1 axillary lymph adenopathy. And then there is a TD volume rendered reconstruction, which is able to, measure the tumor size. And in this case, it was measured as 268 by volume mils. Okay, MRI in musculoskeletal imaging. It is a gold standard in many musculoskeletal conditions. It evaluates joints, muscles, ligaments, and it has very beautiful soft tissue contrast, and it's used in sports injuries for athletes or active individuals to detect injury in ligaments, cartilages, tendons. It also guides treatment planning. Arthritis, very sensitive for early arthritic changes. Okay, so these are a series of images. The first one is a proton density image. And then the second is a T2 fast pinnacle and a sagittal T1. The next is a T2 with fat suppression and the coronal. So if you look closely at the arrows, you will see these hyperintense lesions, okay? And these are osteochondral lesions. And then if you look very well at the Achilles tendon, it also shows Achilles tendinopathy, because on measurement, we found that the anterior posterior tendon diameter was increased, was expanded, and there was increased proton density and T2 intra-substance signal. Another very interesting sequence is the MR neurography. This is employed in even neuroimaging as well as musculoskeletal imaging. So MRI has the ability to delineate nerve tissues, okay? It was first coined by Hull in 1992 in a study, okay? It uses heavily T2-weighted sequence, and it is an important adjuvant to electrodiagnosis testing to diagnose and localize peripheral neuropathies, particularly when the lesions are multifocal or fascicular. It has been shown to influence surgical planning and outcomes by precisely pinpointing and characterizing lesions to guide the appropriate surgical plan. We already talked about the application in neuroimaging, in musculoskeletal imaging. And this is an image that I found really interesting. And if you look at this image, you will see this hyperintense you can also see the other sacral nerves very clearly. In terms of imaging and tractography, MR spectroscopy, which provides metabolic information beyond anatomical delineation. AI, ASL, which we've been talking about here, then the application of portable low and ultra low field MR scanners. I believe Professor John Obungolok has done some work on it, and also Professor Oboli. So maybe they will tell us more about it. So the future holds exciting possibilities for MR, hopefully with less complexities and better algorithms. What are the limitations of MRI? High cost and limited availability, infrastructure, electricity and power supply, especially in low and middle income countries, manpower. We need to keep training and retraining our radiologists, radiographers, biomedical engineers, long scan time, and then some contraindications with respect to metallic implants, and then patients who feel claustrophobic. There are also MRI systems that are designed for this, the open kind of MRI. These are my references. Thank you.
Thank you so very much. And just doing that in good time. We'll just take 2 questions and then we'll be done with that. Yes, it will just be those 2. 1, 2. Thank you very much.
By name Aliu Galadima from Ahmadu Bello University Teaching Hospital. My question goes like this. From the Zoomit breast MRI, is it found in a particular scanner, or is it that any scanner that you can scan breast MRI, the software is there?
Yes, thank you very much for your question. It is a software, and this particular one was by Siemens. So it's actually, it's not found in every scanner, or you probably have to get it installed for some more money. Thank you.
Yes.
Thank you, Ma, for your Labi from the University College Hospital, Ibadan. So my question is also on the Zoomit MRI. So I wanted to ask if you can expand further the role of this particular application in detection.
Sorry, I can't hear you.
Okay, so I said my question up meets breast MRI. So I wanted to ask for its imaging and how advantage as compared to doing the usual dynamic contrast enhancement, or is it used as an adjunct, or it's a replacement for dynamic contrast MRI in evaluation of breast masses? Thank you, ma'am.
Okay, thank you for your question. So the Zoomit employs 2 different radio frequency pulses. Remember that the signal from the basics of MRI physics, the radio frequency pulses are introduced. So this particular sequence makes use of 2 different multiple parallel radio frequency pulse sequences that are, introduced simultaneously. So it captures a higher signal, okay? And then it also reduces folding artifacts and provides better anatomical details. Okay, so it has a better signal to noise ratio compared to other diffusion weighted imaging that we have. Yeah, thank you.
All right, that will be the end of this lecture for now. I can't see any raised hand on those on the virtual, none at all. So once again, let's put our hands together for Dr. Ifeoma Nivo-Abasi. Thank you so very much for that. So moving on, we invite the next person who is going to be talking about understanding low field MRI applications. And the person is going to be speaking to us virtually. Can we confirm that? Close.
Just a minute, just a minute.
Okay.
The speaker is online. Do you play the video or online?
Video.
Video.
All right, the speaker it's already online and we're going to play the recorded video. Take it away, media. But let's celebrate Chloe as the recorded video is being played. Let's put our hands together for him. Okay, while we await the recorded video to be played, I know a lot of interest is being generated around breast imaging, MR breast imaging. And I'm also interested because we know that PET and SPECT CTs are not very much available, and our gold standard has been mammo. And then we've had issues with some teeny-weeny tumors that have been missed. But over the years, MR is being able to solve the problem, except for the costs. And I hope that Dr. Ifeoma will do more around that so that our ladies can be rest assured that whatever it is, it will be picked on time. Yes, please. Let's take it away.
Good morning, everyone. My name is Chloe Naszek. And I'm Berlina. We are both researchers at the Rotter MRI Center here in Leiden in the Netherlands. And today we'd like to talk to you about understanding low-field MRI applications. So here we start.
Yes, before digging into the application on low-field MRI, let's define a little bit our MRI panorama. So here you see a scale of the field strength, and one of the possible definition would be the following. Below 0.1 Tesla, we can define it as very low field, and here you see an example of a very low field scanner from an American company called Hyperfine. Then between 0.1 and 0.3 Tesla, there is low field. Between 0.3 Tesla and 1 Tesla, the so-called midfield. And here you can see a photo of a recently installed 0.6 Tesla in a facility. Then between 1 and 7 Tesla, it's called high field. This is normally the field strength of clinical MR scanner, so you can have in mind many examples. And then from 7 Tesla above, ultra high field. So we can see that in history, there has been a clear trend since its beginning in MRI, both in animal and in humans. So the main magnetic field, the B0, has been increased throughout the year. This happens because there's a number of advantages in seeking higher and higher field strength, mainly higher image quality and contrast. However, in the last 10 years, there's been again a renewed interest in 50 and 100 millitesla scans, so a reversal of our trend, mainly to address one important issue, the accessibility issue of MRI. So why is MRI so incredibly expensive? Well, first of all, we need a magnet, which normally costs 1 milli per Tesla, so 3 Tesla costs 3 million. Then the scanner is normally in a shielded room, which has some cost. And the scanner normally comes with a year maintenance contract, which is needed to refill the helium or to repair any damages. And then it needs to be operated by a trained person, which has their own salary. And all the things that we keep for granted, so reliable high power, air conditioning, and chill water. So as a result, 70% of the world has zero access to MRI. This may be a map that you have seen in the past, but basically you can see that there's a scale with the number of MRI units per million of people. You see it's very colored in North America and in Europe, but the rest of the world doesn't have access to it. This trend is also visible in research. So namely here you can see the number of paper published in MRI. We see again the main contribution comes from high income country, where only 1.3% come from low and middle income country.
So let's talk a little bit about those very low field MRI scanner and particularly their design. So to be able to reach low cost, the very low field MRI scanner are built based on permanent magnet. And what we can see is that two designs have been chosen. One is a bipolar yoked magnet, so these are two plates parallel to each other, and then the Halbach magnet with thousands of small permanent magnet placed in successive rings. And this is a design that we have chosen here in Leiden. Why those systems are low cost? Well, they require no cooling. There is no power needed to generate the magnetic field, and those magnets generally do not require any shielding, so they are not placed in specific room which are shielded. This is a little bit of a panorama of the system that we can find across the world, and this illustrates those two designs. So we can see, for instance, from Europe, 100 millitesla, from China, 55 and 51 millitesla, and from the hyperfine, so USA commercial system, a 64 millitesla, and those are bipolar magnets. And for the Halbach system, we can see here two examples, the one from Leiden with the 50 millitesla, but also the scanner in the US from Clarissa Cooley of 80 millitesla. So as we were just talking about, here in Leiden, we are using the Halbach-based method for building our low-field scanner. And this is an example of the small magnet that we are using. So those are neodymium magnets. They are relatively small. They are just a little bit stronger maybe than a magnet that we could find on our fridge to hold some photos. And we buy them over the internet, basically. And when they arrive in the lab, we usually also have ready to go those rings, where you can see that in those rings we have small square which have been cut off, and those are exactly the size of those little magnets. So once we have the rings and we have the magnet, basically the work starts of pushing each one of those little magnets with the thumb inside one of those placements. Those little squares are cut very precisely, and they are made so that the magnetic field created is as homogeneous as possible. If those little magnets can just even rotate a little bit, this is going to degrade our B0 homogeneity. So once all the magnets are being pushed in multiple rings, we end up with rings which look like that. So here you can see that we have two circles of magnets, and that the magnets are slowly turning along to create the magnetic field. We have multiple of these rings, and they are stacked together, as you can see on this system here. And the distance between each one of those rings is measured very precisely to create, again, a magnetic field which is as homogeneous as possible. When the rings have been all stacked together, we use a robot to map the magnetic field. And then we build shim trays. So this is going to be for passive shimming. So here you can see on the top, those white parts. Those are small shim trays that we have 3D printed in our lab using one of those 3D printer. And inside each one of those trays, we have those little bars, which have even smaller magnets in. And this is going to help us to create a magnetic field which is even more homogeneous, which will help us a lot for the geometric distortion of our images. Then, once the system is all assembled in terms of the magnet, we add up the next part, which is the gradient coils. So you cannot see them here, but basically here inside of the ball, we have X, Y, and Z gradient coils. Those are, again, 3D printed in the lab and then wired up here in our workshop. And then the next stage is the RF coils. Again, we try to build everything in-house to keep the cost as low as possible. So the RF coils older are also 3D printed over here and wired up also here on our station. This part is done. We kind of cover up the system. This is just a little bit of aesthetics. And then underneath the MRI, we add up all the hardware parts. So here on the rack, you can see the RF amplifier, the 3 gradient amplifier, and our spectrometer. So everything is basically assembled within one cart, so that we can move it as easily as possible within the hospital or to other locations outside of the hospital.
Yes, so as we just now clearly saying, we can certainly bring this scanner around, and this is what we did quite a bit in the past year. So as a start, you can see that we get here, we brought the scanner into a conference hall where we gave a demo at a group meeting. But we also brought it quite around for outreach. For example, here we brought it to a cafe for a science festival. Then we brought it to a church, and we even brought it to a hotel. Here you can see Chloe that was being scanned while using her phone. But inside the hospital, we also tested into an intensive care unit. Here you can see the equipment that was already in the room to basically test the potential of this technology for point-of-care imaging, so at the bedside of the patient. And also, we brought it around with the van, so we tested its potentiality also over there. This is quite important to test this technology for as a mobile technology. And indeed, this is something that already another group in the US has been doing. So here you can see a big van in which the commercial hyperfine scanner has been brought around, and even some children has been scanning there. And also here in Leiden, we initially start a conversation with the ambulance department. Here you can see Andrew and Chloe that are looking whether they can fit the low-field scanner into an ambulance unit. Perfect. Now that I brought the scanner into my scanning position, I'm going to connect the power. There is a plug over here. And then I need to connect the spectrometer to the laptop that I already have ready over here. The cable. And now I can turn everything on. So, spectrometer, RF amplifier, and the 3 gradients. This is going to be the maximum sound level that you're going to hear. It's due to the ventilator that we have in the amplifier, so not per se in related to the scanner itself. And actually, these are quite silent, so a person can go in without earplugs. So our volunteer will go inside
without any earplugs. We are well below the threshold for damage in terms of decibel. And the scanner is at low field, as we already know, meaning that we can be in a room like this one. This is actually our office. It's full of equipment of computers, but there is no problem of interaction with the scanner per se. And on top of that is not tracking anything else. So these are the key of my office. You see, I can go quite close. So at this distance, they really don't get affected. And then as I go closer, I start to feel it a little bit. And only when I'm really, really, really at the board, you see that actually they get affected. Now, I would say we'll take the bed in and then we can continue with the scan. Okay, now we put the bed in. You see it's a bed that we just got from hospitals, so from an emergency department. There's quite some metal over here and over there. These are not going to be a problem for our scan. What we need for starting to scan is this belt. So this is a belt made of a conductive cloth, which is inside this plastic cover. We're going to ask our volunteer to put it around the waist in contact with the skin. The idea here is that we're taking the electromagnetic interference that is in the surrounding and is passing through the human body. We're going to ground it to a ground point in the magnet. So we got rid of that instead of entering into the imaging area. This is quite useful because, as you can see, we are in an unshielded environment. We don't have any shielded room. And this is what normally can happen when in a hospital or in a rural area or just outside. So we use this approach to be able to have images that are usable, but hopefully diagnostically useful. And then, yeah, I would say we can start scanning. Thanks, Bea, for willing to volunteer for our scan today. No problem. Before we start with the scan, I'm going to go through the MR safety questionnaire to make sure that you're safe for our scan. And then, since it's a research study, we'll also go through the informed consent to make sure that you agree with the general policies. Sounds good? So let's go with the first question. Fantastic. Then let's check with the informed consent policies. Then can you please sign here? Fantastic. Then we are ready for our scan. So can you remove your jewelry, so your necklace and also your earrings, and also take the clips out of your hair? Yeah. Okay, perfect. And then, yeah, and then I'm gonna give you the belt to place around your belly, like we described before. Perfect. Then I will do it. Please come in. All right. So you can come up and sit on the table. Up so you can lie down. And you can help yourself with your hand to go inside the scanner until your shoulder basically touch the side of the scanner. Yeah. You're good in position? Yeah. Okay. Then I'm going to connect the belt to our grounding point. Yeah. And I'm going to put a pillow underneath your leg. Up. And we're basically ready to scan. Here is our scanning interface where we set all the parameters. The first scan we run is just to find F0 to get our center frequency. And then once we've got that, we run an auto shim procedure. So this is using the X, Y, and Z gradients to produce linear shimming. So we start with a zero value on each one of them, and then it's progressively increasing the value on each one of those gradients until we've reached the best homogeneity. And this is tracked by looking at the height of the peak, which we can see in the right graph, and the highest the signal, the best the shim is. And at some point, basically, the system cannot improve more than that, and it's reaching a plateau. And this is when we know we can stop the shimming procedure. So here we can see that it could increase a little bit more. So I'm continuing from those values. So here it looks like we've reached the plateau. So I'm stopping and saving the value. I'm running a new center frequency find. And then after that, the last optimization procedure is looking for the power needed to get the flip angle for a 90 and a 180. So the power needed to get a 90 and a 180 degree flip angle. So here we are sweeping through different power, and we will see the signal progressively increasing until it reaches its maximum, which is where you have the 90-degree flip angle, and then it will start decreasing until it reaches its minimum, which is when you have your 180-degree flip angle. So here we can see the max is between 15 and 16 decibel. And that's the power then needed for the 90 degree. And then it's going down. And then here is our minimum around -10 dB, and that's the power we need for getting a 180-degree flip angle. So then we take our scan protocol. Here it's a 3D turbo spin echo, and we want to run a T2 weighted scan. So we enter the value needed for our 90 and 180-degree flip angle. We've set up our field of view for scanning and the number of phase encoding. We've defined our trajectory as being linear because we want to get a T2 weighted scan. Our repetition time is close to 2.5 seconds, and our echo time 150 milliseconds. To be able to scan a little bit faster, we are using circular windowing and half Fourier factor. And then we are running just one scan, and this will take us about 8 minutes for a resolution of 1.5 by 1.5 by 5 millimeter cube. Okay, so we are done with the scan, so you can come out now. I'm disconnecting the bed, and you can just come and slide out of the scanner. Perfect. How was that? Yeah. How's that? Yeah, it felt comfortable, very comfortable, super comfortable.
Great. So until now, we've talked about very low field MRI scanner and the different design that we can find across the world. We've shown you that the system can be portable. Goes through a scan session with one of our scanner. And now I think it's time to look at some images that we can get with our scanner. So here you can see three imaging modalities: the T1 weighted on top, the T2 weighted in the middle, and the short inversion recovery T1 weighted scan at the bottom. So while the T1 weighted and T2 weighted are quite conventional scan, the short inversion recovery is something that we've set up talking with an radiologist here in our hospital, and it's basically here to create more contrast between the white matter and the gray matter, which is something which is very tricky at very low field due to the very similar T1 and T2 relaxation time. And you can see that even though we have a very low magnetic field strength and a resolution of 1.5 by 1.5 by 5 millimeter cube, we still can get quite decent image quality. And I would like also to emphasize that those images have undergone no post-processing, there is no denoising, no filtering whatsoever. And if we look at the T2 weighted or the short inversion recovery, we can see that even the deep gray matter structures, so the putamen, are quite nicely recognizable. Those three sequences are 3D turbo spin echo, and on the right side you can see the duration of those scans. So the T1 weighted is our shortest scan, about 4 minutes, while the two others are close to 10 minutes each. So this is still quite long if we want to talk about clinical relevance, but we are currently working on speeding up those acquisition. Now, those were images of healthy volunteer, and we wanted to start looking more into the feasibility of detecting pathologies. And we scanned the subject with non-benign white matter hyperintensity, and we performed 4 different scans. The 3 that I already mentioned, so the T1 weighted, T2 weighted, and the short inversion recovery, but we also did a FLAIR scan, which is a common scan in the clinic. And now we can see both in the T2 weighted and in the FLAIR scan and the short inversion recovery that those white matter lesions close to the ventricle are quite nicely visible on those scans. So these were examples from our Halbach scanner, but from the literature we also can see some example using from the Hyperfine, so a 64 millitesla scanner compared to a 3 Tesla here, and we'll have example of few pathologies, so the stroke, the intracerebral hemorrhage, cardiac arrest, pediatric hydrocephalus, and again, like in our cases, white matter hyperintensity. And where, of course, the very low field scan has a lower imaging quality, we can see that the pathology could still be identified. Here, focus a lot, of course, on neuroimaging, but since last year, we also started to scan extremity imaging, especially at wrist. Here you see an example of a standard T1 weighted scan from my healthy volunteers. At the same time, we're also started to scan patients with rheumatoid arthritis, and these are some of the first results. So you see, especially compared to 3 Tesla here, you can see hyperintensity, which is also present at a 47 millitesla. You can see that the image is much more noisy and more coarse, as already also described by Chloe before, but the pathology is still visible in the first 2 fingers of the hand. Same goes for another volunteer, which had accumulation of fluid on the second finger, which is already very, very visible at 47 millitesla. And finally, also in the wrist of a patient, we could identify accumulation of fluid due to the rheumatoid arthritis. So this gives us hope that this type of technology can also be used not only for neuroimaging, but also outside. The same, of course, has also been investigated around the world. There are important examples from a few groups, for example, from the group of EDVU in China. They've been building whole body imaging with impressive results going from the brain down to the knee. Then the group in Valencia has been focused a lot on knee imaging, with also trying the scanner in different locations, evaluating the image quality. And also some example of electromagnets, so here for breast imaging from the group of Matt Rosen. So all this to say that we can label now imaging in different parts that for now have been not be usable, reachable by low field. And in terms of imaging opportunity, we can also talk about pediatric scan. So you've seen, or better you heard, that the very low field scanner is quite silent, and we saw that Chloe could be very close by the volunteer while scanning. So this makes it an ideal imaging modality for pediatric scan. So here you can see some images that are taken from infant and using the hyperfine scanner. And at the same time, you can see in the video how easy it can be to wrap a neonate and just put it into the coil. So certainly this is a technique that could be very useful to have, for example, the parents of the kids close by, or the technician, or the clinician that can monitor at all time the baby in the scan. And in terms of other imaging opportunity, we can also look at patient with implants. So here you can see standard implants that can be found in the human body. And we know that when these implants are scanned at clinical field strength, so 1.5 and 3 Tesla, they present the so-called this shadowing that is called the susceptibility artifact that increase with the B0. So at 7 Tesla, you get the worst susceptibility artifact. But on the opposite side, at very low field, we have limited to no susceptibility artifact, meaning that we minimize or basically not have this effect. If you look, for example, at the iliac stent, we can see that you can see through, and it's quite transparent. So very low field can enable imaging for patients with implants. So for a population that was prevented from using this imaging before. Also, there has been an example of Halbach scanner, so the one that we have here in Leiden that was built around the world. There were a workshop where people gather and build the scanner itself. So you see 2 examples from Uganda, but in the last year we can also count examples from Paraguay, Singapore, and South Africa. So, and maybe in the future that will follow. So with that, I'd like to talk both from myself and for Chloe, saying that it has been a pleasure to talk to you today, and we hope you found the talk fun and interesting enough. It's a pity we're not there with you, but we still hope you can have a great day and enjoy the rest of your talk. So thank you for your attention.
Thank you very much, Chloe and Benina. That was quite impressive. We'll take 2 questions. If you have questions for them, you want to tell us where you want to build your own MRI machine so that we can let them know. Are there questions online? You have a question. All right. Take it to them. Okay.
My name is Precious Mhlanga from Zimbabwe. Thank you very much for a very insightful presentation. I wanted to ask how many departments you involved in coming up with such a comprehensive machine. Did you involve the physicists, medical engineering department, etc., etc.?
Hi, I hope you can hear me.
Yes, loud and clear.
Great. So it's Chloe talking here from Leiden. Unfortunately, Beha had to move to another meeting. Thanks a lot for your question. So a lot of the work is being done within our department, so which is the radiology department. But we also in the past had work in coordination with more engineering department. But I would say at the moment it's mainly the radiology which is involved.
Thank you.
Okay.
Yes. Okay.
Thanks for the beautiful lecture. My name is Jude Dimba. I'm a radiologist from 44 Nigeria Reference Hospital, Kaduna. Actually, I looked at the images. They are relatively good, considering the price of the low field MRI and the portability and other advantages. But my question is, I noticed that your colleague used to do the test. She didn't wear any earplug, although the ball was quite narrow. So what's the noise like while doing this study compared to bigger MRIs with higher Tesla? Thank you.
Yeah, that's a very good question. So there is basically no noise from the MRI scanner itself. The only real noise that we have is from the ventilator, from the gradient amplifier. But performing the MRI itself is, compared to a traditional MRI scanner, we are used to them being quite loud, and that's why the scan is done also in a closed room. But on our scanner, there is basically no noise coming from the gradients. They are a lot weaker compared to traditional gradient amplifier on conventional scanner. So the volunteer doesn't need to wear any earplugs, any headphone. The noise is basically inexistent. Only when we're going to be doing some diffusion weighted imaging, then we're going to be pushing the gradients a little bit more, and then still the level of will still be so low that we don't need to have ear protection.
Thank you very much, Chloe. My name is Samuel from Nigeria. I'm a radiographer. So I wanted to ask, is there any role or in terms of the size of the anatomy being examined? For example, I discovered that it looks like the balls are fixed sized and there is no separate, transmit receive coil. So that if the size of the patient is quite small, does it lead to signal drop? And also, I think let me go with that. I forgot my second question.
Yeah, that's also a very good question. The bore of the scanner.
Can I just interrupt? So you just take it one. I also noticed that you don't have a gradient echo image on. There was no gradient echo image. Is it possible with a low field MRI system?
It is possible to get gradient echo image. It's just something we are not really using. We are mainly using our turbospin echo sequence for our protocol. But to go back to your first question about the sizes. So as you can see, indeed, the bore of the scanner has a fixed size, and how far the person can go inside the scanner is limited basically by the length of the neck of that person, because your shoulder are going against the front of the scanner, and then your neck and your head is lying inside the MRI. And we are using a coil which is both transmit and receive at the moment, and it is indeed kind of a one size fit all. And we've experienced also that this is not always the best case, because we've had cases of volunteer which are then not fitting inside the coil. So we've then now also expanded a little bit our, let's say, number of coils, where we have some larger ones to fit person which would have maybe a larger head. The only thing is then the coil will be a little bit closer to the bore of the scanner, and we know that this will have a little bit of an effect on the SNR. If we would be scanning babies or kids, then we would design a coil which would be smaller in size.
Hi, Chloe. My name is Uche. My question on the part of safety. I noticed you moved the machine from one room to the other for the scan, and there were no precautions taken. Is this completely hazard free, or could there be any hazard relations to the size of the mag? Thank you.
No, there is no real limitation on how to move the scanner around. We are not taking any specific precautions to move the scanner from one room to another. We've taken it outside of the hospital, within the hospital. We've taken it inside the elevator, from different room. We've put it in a van because it's a very low magnetic field. We don't per se need to take any specific precautions.
Thank you. My name is Kudrat from Nigeria, the radiographer. Thank you for your presentation. It's amazing to see that we have scanners that are mobile, that can be moved around. But my question borders around maintaining the homogeneity of the magnetic field. What sort of shimming system do you have in place to maintain homogeneity?
Yeah, so the way the magnet are organized around on the rings is optimized to create first the B0 in the most homogeneous way. Then after that, we are mapping to get a real B0 distribution inside our scanner. And then around those magnet, we add what we call shim tray, and this is going to do passive shimming. So based on the starting distribution, we can add additional small magnets all around to reduce even more the inhomogeneity and get a B0 which is more and more homogeneous. And then once we have the best scenario for our build scanner, what we use is active shimming using gradients. So we use the gradients for linear shimming. First order shimming. So we use X, Y, and Z for each of our volunteer to shim to bring the homogeneity even further to a better level within our field of view. I hope that answers your question.
Thank you. My name is Amdada Abiodun. Thank you. I know we met last year in Tanzania. I wanted to confirm whether this is the same as the one you did that you presented last year. Then also to confirm about the costs. Then another question is, how long did it take you to build this? And on a lighter mode, how can this be produced in Africa, and most especially in Nigeria?
Yeah, yes, I absolutely remember meeting last year in Dar es Salaam. So nice to talk to you again. So this is indeed the similar system that I talked about last year. And this year we've focused on really accelerating our images, our acquisition further. So our work this year has mainly been from the sequence point of view, because our scans still remain relatively, I would say, on the long side. And we want to bring that to even shorter scan time. So this has been our focus. Then your second question is, I think, the cost of the system. Of course, we are a research unit, but there are more and more small companies which are currently emerging and want to commercialize the Albar system. And I think the target price is around 150,000. So I know that this is, for instance, a lot cheaper compared to the price of the Hyperfine at the moment. And then you asked about the time that it takes for assembly. So once we have all the pieces in the lab, so the rings, the magnet, and etc., it takes about a week to assemble the whole system. Of course, you need to be a few people to help out. It's not just one person, but that's about the time that it took here. And I think that's also about the time that it took in Uganda for them to build the system when they had all the equipment. And I think maybe you had one last question, which you might need to remind me.
What's about to is in
Sorry?
Nigeria?
How to, yeah.
This is Nigeria, most importantly.
Yeah, so I mean, I know that, for instance, so there was a project, of course, in Uganda, but I know that Andrew also back in December went to South Africa, and I think, I mean, we're more than happy to provide support. I think things also will work well if they are also built from inside. So yeah.
Thank you for this interesting question. I just have one question. Since it's less yours in terms of the strength, what was of the safety check?
I'm very sorry, I couldn't hear your question.
Okay, that the purpose of the safety check on the patient based on the field strength.
That's also a very, very good question. So what MR safety we should do? And I think at the moment we are still being a little bit conservative in the way that we're still going through those MR questionnaire, because it's a novel device that we built on site, and that there are no clear, written policy and regulations. So we're still going through the MR questionnaire, but of course, because it's a much lower magnetic field, then the risk is much less compared to the conventional system. So that's why people with implants can be also scanned. And that's why we have to take less precaution, I would say. So the only thing that I asked Bea to remove was the clips in her head and the necklace, because it would still be attracted at that point to the bore of the scanner. But yeah, I think more tests still need to be done to make sure that no other regulation need to be followed.
Thank you so much. Thank you so much, Chloe.
You're
Thank you. Let's give
welcome.
Chloe, thank you so much for that. We missed you, or we miss you, Yeah. So we're hoping that you built in South Africa, you've built in Uganda, you've built in Paraguay. We'll definitely collaborate with you to build in Nigeria. So looking
Sounds
forward
good.
to sometime next year.
Sounds
All right,
good.
thank
Bye.
you. Bye. Enjoy the day. So the day is getting a little bit long. Just before lunch, I would like to invite our next lecturer, who is going to give us talking about MRI safety. We're going to give her 30 minutes. So we invite one of our top radiographers in Nigeria, a former president of the Radiographers Association of Nigeria, a prominent speaker, and also well-traveled, published author, businesswoman. She'll be talking to us about MRI safety. She's one of the prominent radiographers in Nigeria. So you have 30 minutes so that we can go for lunch. And after lunch, we'll have another lecture by James G. Then we'll break out to the session. It's a long day. So Mrs. Elizabeth Balogun, you're welcome from Ajayi Crowther University. Thank you.
Thank you very much. I was so excited when I found out that Chloe and Bernard still went ahead to do the safety checks. Because you can never know, we're still doing our research to be sure that it's actually safe. So I grew up in this part of Lagos. I have visited this part of Lagos. I work here at Ajayi Crowther University, Oyo State. And my name is Elizabeth Balogun. Thank you. So these are my outlines. We do a bit of introduction. We look at the safety rules, screening guidelines, hazard risks, side effects, and of course, safety guidance. We're not new to MRI, so it's a non-invasive, non-ionizing imaging modality. It uses magnetic fields and radio waves to produce detailed images, and commonly used in neuroimaging, musculoskeletal, cardiac, and abdominal studies. These are the components you should know. As clinical practitioners, we try to run away from the physics, but then it's always running after us. So this is just a little reminder to show us that we have the main magnet itself, the gradient coils, and the RF coils. So why MRI safety? First, the MRI environment poses unique safety risk, which we are all aware of and which we'll look at further. The magnetic field is always active. There's no on and off, it's always on. And so this poses a potential for serious injuries if the protocols are not followed. And we are all involved, every one of us in the imaging practitioners in safety, while radiographers are the safety enforcers. And somebody will say, why? You are the last person with the patient. So safety and hazards. Safety, the condition of being protected from or unlikely to cause danger, risk, or injury. While hazards are just danger or risk. MRI, hazards, and safety. There's the safety concerns in MR, which arise from three major sources, like I've indicated earlier. The first and foremost is the static magnetic field, which is the main magnet itself that has the ability to pull metallic substances to itself and actually realign them. We also have the gradient magnetic field, which are the gradient coils. And of course, the RF magnetic fields, which receives and also sends the magnets. So the static magnetic field, otherwise known as the B naught, sometimes gets up to 3 Tesla in clinical settings. I'm not sure, but generally in Africa, I think we've stayed just within the 1.5. There will be just a few, 1 or 2 centers in Africa generally that has the 3 Tesla, because the higher the magnetic power or energy, the more hazardous it is. Also, the gradient magnetic fields, which is usually used for the spatial encoding, and the RF fields, which cause tissue eating, and this is why we need to monitor the specific absorption rates in our patients. There are MRI safety zones, according to the American Clinical Radiology Guidelines. There's the zone 1. And this, I don't want to speak over our head. I don't just want to speak about what we should know, but that's what is practicable. We all know that back home, we may not have the opportunity of those large space. I did my master's in University of Leeds and the teaching hospital there. Before you can see the MR machine, it's like going through, like you're going to see a prisoner, even to say hello to the radiographers there. All these are being maintained, but for lack of space and fundings, most of us can just turn like this and see the MR machine. But does that mean we cannot maintain these zones? I don't think so. We can have all our checks as if the zones can exist in our virtual mind and helps us to keep the safety of our patients. The zone 1 is the general public area. We can look at our patient sitting area. The zone 2 is where we interface for screening and supervision at the point you talk to your patient. Make sure you are able to actually do the MRI for them, not until they get close to the machine. And zone 3, which is a restricted area, access only for screened individuals. We'll talk about this again. And zone 4 is MRI scanner room, which is the strictest safety control place. So what are the MRI safety risks? We have the projectile hazards, where there could be metal objects turning to become missiles. There could be thermal injuries from loops of the lids, tattoos on skins of the patient, or metallic clothing. There could be implants and devices such as pacemakers, cochlear implants, etc., which may malfunction due to the MRI or the magnet. And then the acoustic noise can cause hearing damage. There's no solution to that. For those of you who have actually had an MRI scan, even when the plugs, I could still hear the noises. So they are there. And so we must try as much as possible to limit it. We may not be able to stop the patient from hearing those noises. So if you are aware that those noises exist, we don't want them to have hearing damage from them. So there's the patient screening protocols. It must always complete an MRI safety questionnaire. I was glad we just saw that video from Chloe, and they didn't take chances at all. She went through the questionnaire with the patient, and that is what we should do. We should ask about implants, surgeries, and metal exposures. I want to stay on this, especially for those of us in Africa. I give it to our brothers in East Africa. We had a conference there, and the entire conference was done in Swahili. Hey, we know that the way I speak my English as a Nigerian may not come across to her as I'm speaking English, if you get what I mean. I'm speaking it with a bit of my accent. So we should have that at the back of our mind when we're running through the questionnaire with our patient. Try to be sure you are communicating. They may not understand what you're saying. You may have your own terminologies. Be rest assured that you get a feedback, because that is communication, from that person you have communicated with, to confirm that they actually understand what you have said, not that they are just shaking their head and we run into trouble. We should make them remove all metallic items, jewelry, watches, and hearing aids. From my experience, I know that in the UK, they do a bit of disclaimer, because when I was going into the machine, I asked if I should remove my wedding band. And by their own policy and law, if she tells me to remove my wedding band, I could turn around to say she made me remove my wedding band and made me divorce my husband. And I can sue her for that. And so she said, Elizabeth, you can keep your wedding band. And then I went into the ball, and it was as if some, you know how we say it in this palace, village people followed me. And then the thing was just doing a lot of banging on my wedding band. I didn't need to ask her a second time, and I removed it. I called her, and she brought my bag, and I dropped it in. You know the protocol, she's not permitted to collect it from me, but I had to keep it myself. So please, let's take that into consideration. There's also the consideration of claustrophobia and need for sedation. I mean, from the ASL lectures, I get a bit weary for sedation, except it is highly needed. I've practiced for 25 years in orthopedics and accidents and emergency, and I will tell you that I've dealt with, as at the last count, 1,102 children in my practice as an accident and emergency radiographer. And I can boldly say that throughout that practice, I've only asked for sedation for one child. And so I want to encourage the young ones. By the time I was leaving, the young radiographer that came in was practically requesting for sedation every week. And I was like, where is this coming from? If it will take me to dance for that child to get to know me, I'll do it and calm the child down. So there are MR labeling devices, just a reminder. We know when it is green, no known hazards. When it is yellow, safe under specific conditions, which you must know. And the manufacturers will write it there a lot of times. When it is MR unsafe, then it is color red, which means it's known to pose a danger in MRI. So you must always check manufacturer guidelines before you deal with it. So these are also the pictorial explanation of what I've just done. So what are our roles as staffs? We have responsibilities, not just to our patients, we have responsibilities to all the staff, we have responsibilities to ourselves. You know, as a radiographer, I've been to a center before, and you know, out of excitement, oh, you've got this new MRI machine and all that. And the person just stood up, good morning, man. I said, good morning. And I peeped my head, and something was just doing my hair like this. And I ran back and I said, oh, you didn't remind me I needed to say, I'm sorry, ma. So we hold responsibilities, not just to our patients, to every staff, including medical imaging staff. I've had times when my hands were already on the button and I'll be saying exposing, and the radiologist will say, hey, so I say, oh God, leave the room. You know, you get carried away with your work and things that you're doing that sometimes you also forget about the environment where you are working. So the responsibility is first knowledge about what you're dealing with and who are you dealing with, the physics, the technology, the patient screening and preparations. Review it all the time. Have your SOPs, tag it on your machines, tag it on your system, especially when you go on leave and come back, and especially maternity leave when you've been away for a long time. So you need to review a couple of times, as well as staff screening. You know, some of us, for instance, this is, I won't mention him and I won't say it, where the first man in Nigeria needed to do an MRI. And then he went into the machine and that. I'll leave that. I also had another one, a senator, and she had, you know, a heavy makeups, the one that is shining very well and all that. And everybody were like, who will tell her to wipe these things off? Because those things are actually metallic. And after we have asked her to change, we have removed all the metals. We're not comfortable with those makeups. And to communicate it was like, is your job still secure? And then by the time we started, it was looking like a heavy artifact on the images. So we brought her out again and we showed her. And she said, is that my eyeballs, or what is popping out there? Madam, it's your eyeshadow. She said, what? And so we didn't need to tell too much story, and we asked her to clean it. That took a while, but she was able to do it. But sometimes we get challenges with all these things. We get celebrity freak. So there's also the patient care and communication. Always know that you owe your patients that duty. Someone cannot pay, especially in this part of the world where we do a lot of out-of-pocket payments, only to come and get injured. Rather than, there's also the do no harm, you know, and do good at all times, that we owe our patients in ethics, and that should come to play. Another thing is the safety protocols, like the safety checks, going through the questionnaires. Never be in a hurry and never miss any of these steps. Education and training, like we are all here now, learning more. I'm sure in these last 3 days, I've learned so much that I'm beginning to think again if I actually know what MRI is all about. You must continue to develop yourself, learn, get mentors, and be better at what you do. And there's also need for higher level of specialized competencies. Like this morning, Professor Danny was also able to take us through the advanced imaging in ASL, aside from what we did at the boot camp. So there are emergency responses. Do we get emergencies in MRI? Yes, especially the quenching. And so we must be prepared to respond to emergencies such as patient distress and technical issues with appropriate actions and interventions, but not at the risk of your own safety. You must be sure your safety is also not compromised as you respond to these emergencies. Otherwise, just cry out for help and let other people assist. You must inspect your equipment at all times to be sure that it operates safely and safety effectively. There should also be the administration and governance, which is policy development and implementation. If those things are there, established by the center, it's easier to follow, and it's written down 1, 2, 3, 4, and then you won't need to convince people because it is an administrative thing. Like the safety and risk assessment, training and competency assessment, and incident investigations. Whenever there's an incident, it must be thoroughly investigated for us to know how it happened and how it can be prevented another time. And of course, the regulatory compliance, which will be different from country to country and from state to state. At least let me remind us, health is concurrent and it's community-based, and so it may not be generalized at all times. So pediatrics and sedated patients are like a special care. We must take extra care due to movement risk, especially in pediatrics. We must ensure all monitoring equipment are MR compatible. We must use immobilizers and provide hearing protection. So now we're going to talk about some real world examples of MRI accidents. I've just decided not to put the pictures we are all used to. And I wanted us to just speak truth to what we have seen. I'm sure seated in this room today, most of us have not really firsthand witnessed these accidents. We've seen them in pictures, we've seen them on social media, and we've thought that, oh, we are good about it, and so it will not happen, and it has not happened to us. Luckily for us, in Africa, most of our MR are low field. We actually started with 0.2, and the 1.5 Tesla we are bragging about now, we can actually count them on our fingertips. So that has also not exposed us to major accidents. I'll share my experience. I've told you the one that my ears were, we do that to children to tell them, listen to me. So the MRI machine told me, listen to the instructions. Another one I had, it's a pathetic one. I may try to not mention the center. I was there, and there was a game going on, and we're using that center under 17 World Cup. And then I had to get there early. I was on duty that day. We're training as well. I don't work there. And so I saw a young man was in the MR room, and the man was using a mopping stick that has a metal handle in the MR room. I initially looked, is he having a health challenge? Is there a problem? And I looked at the mop stick and I saw what he was holding. I didn't go near him. Remember, my safety first. I called him out and he came out. And I said, is this your first day working here? And he admitted, yes. And I said, do you have phone and ATM cards in your pockets? And he said, yes. And I sat him down and I started explaining to him. And I took him to the head of the department. And the department exonerated themselves. They said they've spoken to the support staff that they should maintain a person they keep training and training all the time. And this had not happened. You know what I mean? This is a guy whose salary may not be able to buy another phone in 5 years. For that day, he has lost his phone, his ATMs are damaged, and I'm sure he didn't know what was wrong with him. He said he was thinking, does he want to fall? Does he want to faint? He didn't understand what it was. And I didn't let it slide. That day, we had to address the entire support staff while we make him to share his experiences. And so many like that I have witnessed, and because I didn't just want to mention those centers, they are mild. They are things you don't think about, but they happen around us. We have inadequate screening. We have one that has stared us in the face in the last 3 days on our social media, when the husband of the woman ran in with his heavy chains on his neck. And one we wonder if they had done that zone 1, zone 2, even when it's an accompanied person. Have had an instance where a governor and the wife came. We took the governor to a VIP room and we only received the wife to take to the MRI room. So I will still blame it on whoever is at that center and scanning at that time, because what you call that is unauthorized access and improper labeling. So this is a citation from Prof. et al. That talks about the number of MRI we had in Africa as at that time. And we looked at the number and how they are spread. One thing in this paper that has confirmed is the fact that most of the MRI are also low field MRI. So we are happy the cheaper low fields are also coming up. And for those who have been in lawsuits in the last 2 decades, the first MRI was brought to this hospital just to establish history. And it was a low field MRI. Actually, it was just for the knee, but we didn't know what it was and what the use was. So we got trained and everybody just went to sleep. So most then were at 0.2 to 0.5, and we didn't have big issues. But here we have with 1.5 and 3 Teslas, and all these are already happening. Ladies and gentlemen, the takeaway and the summary for us is that MRI is safe with strict adherence to protocols. Whether celebrity, whether your boss, whether your colleague, you must keep it strict and strict. Radiographers are the first line of defense, and you must know what you're doing at all times. Continuous training is essential. Safety is everyone's responsibility. These are my references. Thank you for having me this afternoon. I'll be open to questions, and thank you once again. Thank you.
Thank you very much. That was a good one. Very, very beautiful talk and very right to time. Please, we'd like to take 2 questions and then we'll go for lunch. We are thankfully on schedule. We've gotten back to schedule a little bit. So let's have 2 questions. All right. Ifeoma, 1. Any other question? 1 more.
Please, I have a question online. There's a question online. Question online.
Go ahead and speak online. Then we'll take the question on site.
Thank you. Thank you very much. Hello, can you hear me? Thank you very much.
No. Go question online. Go to person online first. The person online, go ahead and speak. Ask your question.
Good afternoon. I'm Rad Victor Chukwu, the senior radiographer at Dave Umahi Federal University Teaching Hospital, Ebonyi State. In the course of the lecture, the presenters made mention of sedation in pediatrics. So I want to know how possible is she to achieve MRI procedure for pediatrics without sedating them, because we know that there is need for absence of motion during MRI procedures, and pediatrics, even from 0 to even 6 years, they can hardly be stable. And in my center, we normally advise for sedation. So I want to know the procedure she uses to achieve that without sedation. Thank you.
Sense an emergency. All right, thank you, Rad.
Victor.
I missed Victor. Okay, sorry. Well, I wasn't. It was not specifically for MRI, because I still mentioned that sedation is needed in MRI. I was talking about my practice as an accident and emergency radiographer, where I've dealt with a lot of children, and I've been able to avoid sedation as much as possible. But in MRI, for children, it's needed. But then there are also some disease conditions that makes them already have sedated. Someone who has a lot of fluid in the brain and all that, they are already calm. You may not need to sedate. So what I mean is that don't just make it a routine without investigating and knowing when it is actually applicable and non-applicable. That's what I'm trying to establish. Thank you.
Okay. All right. Thank you. Thank you very much.
All right, let's have Ifeoma with a question.
Thank you, Elizabeth, for your lecture.
Mic is not on.
Okay, thank you very much, Elizabeth, for the wonderful lecture. My concern is actually how do we differentiate between the MR compatible devices? Because I know that abroad now they have compatible devices which are no longer absolute contraindications to MRI imaging. Now, in this part of the world, how do you differentiate? Do you get to ask this patient, and how do you actually agree with what they have on maybe the cochlear implant or the cardiac pacemaker is actually compatible? Thank you.
Thank you very much, Dr. Ifeoma. Well, for when the patients already have it in them, before those things are done surgically, they are told. I've had a procedure where the doctor actually told me, I know you are a radiographer, although I didn't do it eventually. I'm going to make sure it's MR compatible. You know, he was trying to convince me that whatever my fears are, I should accept the procedure and that it's going to use an MR compatible. So even in orthopedics, when it's going to be used, first, you know, it's more expensive. It's labeled from the manufacturer. And so the doctors, physicians, surgeons, we communicate to the people. And they know I have an 80-year-old woman. She was coming to have an X-ray done. And she just say, hey, that I have pacemaker that is MR compatible. I said, what does that mean? I don't know. They say I should be saying it. So people are aware. They will tell them, or you ask again and again. And if you're not sure, you can use the metal detectors to actually screen them. And most departments, especially where they don't have the long passage at zone 1, zone 2, they actually have the metal detectors to apply. Thank you very much.
All right, thank you very much. I think we've had a wonderful time, and we're going to move to the next phase, which is the most important phase and the most interesting phase.
I had one question again from the online. There's a question again.
Okay, go ahead and ask your question. Bonus question.
Hello.
Go ahead.
Okay, Steve Victor Chukwu. In terms of the safety protocols, most times we see some patients present and they have a history of having implants, but they are not sure of the MRI compatibility of the implants. And now most times you ask them to go back and get a certification from the doctor, and most of them cannot get it. So in that process, what can we do? Should we proceed? Or because sometimes I do just take an X-ray, but in the place where the X-ray is not available to just carry out on the patient, what can the radiographer do in such case?
Thank you very much. Those taking X-ray, I hope somebody will arrest you for that. Well, that's what we're doing in isolation. You know, most of our physicians don't understand what we do as imaging practitioners. A couple of them were with us yesterday, and someone acknowledged the fact that he was lost with everything we're talking about. So yes, the doctor could request for the if the patient, please, you cannot be too safety conscious. Make sure that the certificate is gotten, or you scan with your metal detector, or you make sure that ask all the questions, let the person go back. But the awareness is getting more. And in your hospital, I will encourage you, if you people do joint seminars, and if you don't, like in my hospital, when I was in the clinical, once in a year, each department is rotational, you are presenting. So when there's a new thing, you come to talk to everybody about it so they know what to do and how to do it. So in a situation where there's one-eyed man, is the king of the blind. But when all of you know what to do, it helps everybody to know what to do. I hope that helps.
Yes, thank you very much, ma'am. That's interesting. Thanks.
You want to come out now?
Yes, 5-5.
All right, thank you. Thank you for that. A round of applause, thank you. So for lunch, we're going to make, lunch is going to be very methodological or precise. So we're going to go for lunch in groups. So we're going to go in groups of 5, okay, because of space. So we're going to say this is A, B, C, okay? So we take, okay, we'll go in group of 6, 2 from here, 2 from each group, so that we can not crowd because the space is small. Is that okay? All right. So we can start from group A, 2 people, from group B, 2 people, and like ushers will guide us. All right?
Oh, yeah. Oh my God, what a feeling. The Versace and the Miri. Come take my ring, got me. Oh, so much you gon' go. Feet party, you gon' go. And I drop my clothes, them they fuck with my son.
Lunch is out for 20 minutes. By 2:30, we should be back for the lecture by James G. The master class for radiology has been suspended till tomorrow morning. We're starting at 9 tomorrow morning because Nevedita, who is supposed to lead the class, has another session in Italy. So the master class for radiology is cancelled for this afternoon. We'll just join the radiographers and the paramedic imaging group, which we hold in this room. Okay? Okay, any other question? Any other announcements? All right, thank you. All right.
When I drop my bedroom, they fuck with my son, no condom. Hold on. And if they ever a day with you, I'll let you for living fearless and Maradona, the beast in that lie. Cinderella. Oh my God, what the feeling? If Versace and a beauty, don't live by the jet, really, also, choke on, be ready, choke on. I do the people, so, shut up.
Anyway, scatter area. No, no, making this one. She might not wear it though.
Motherfucker be the president of Puerto.
Desperado. Many, many. My amigo. I'll tell you. Ladies to give me a photo. Paparazzi. Don Julio. Don't tell me. Egumedola, Pistas Aola, Azametra Ola, Lao, Egumedola, Pistas Aola, Azametra Ola, Lao, yeah, Lao, Lao, easy to stay. Not be my weakness. Me and you not get to business. I take my kindness for weakness. Softly, you know, go to my singlet. Oh, boo, get the lynch. No, they joke with my percentage. No, go give to Caesar. What belongs to Otogu? What is you at all? The money over their love. Money no like cha. Oh, one more feet, Gaza. All in one, bro. Yeah, my son. This the chance for your dog. He pistas aula. As a metro. Ni pistas aula. As a metro. Yeah. See me up because we are talking to me. The Christmas of a boy, Smith, no, some players, it's me, go, it's me, tell you, you can talk to me like this. Yeah, for be a while. Yeah, so, Minister of Enjoyment, it's a continental, monumental, goalie forever, another the matter must be meta. Smoke is asa, make that forget your mother.
Do a program and leave, but like maximum 4. Yeah, this is tomorrow, yes. So this is your host in Ibadan.
Yes, of course.
So I was asking him what program. Yes.
Okay.
Professor Dari.
Dari. Okay.
Dari.
That's an easy one.
So,
Okay.
So I was asking him about the program.
Yeah, of course. You see our studio, live studio, meet with some staff of the department. And also we have asked the Kontali students to be also the studio to have a chat with them.
Wonderful. Looking forward to it. So do I need to give a talk or just be there and talk with the students?
Yeah, can give it talk.
No, it's up to you. I would rather talk to students than give a talk, but
Like general, like just a general ideas. That's what you mean. Not a full PowerPoint talk like that. Just like a general talk.
okay, it will be like a 5-minute talk then. Just,
So it can be up to 20.
okay.
Just a motivational talk.
But I'll do that. Okay,
Up to
okay,
20 minutes. Still.
Okay.
So students may still ask you questions.
That would be
Well,
great.
the plan is this. So he's taking you to Lagos. You will go with
No,
his team.
Ibadan, not
Oh,
Lagos.
sorry, to Ibadan. So we will start here at 9 tomorrow.
Okay.
I do the first preliminary things, and you leave by, of course, we are coming with our t-shirts, everybody's coming dressed, you understand? But your team, which should be like, I estimate, you're going with 2 or
Oh shit. Family, oh my God, what a feeling. Take Versace and a miri. Come take my ring, got really for someone. You gon' go, feel bad, you gon' go. When I drop my bed, do them, they fuck with my son, no condom. Hold up, them they tell us fire for. And if them back on, I live it, you will look you for. Live see, let's have I do not the beast, sing that I. Cinderella, you got Jenny on the stuff. Jora, but give my baby do the doctor. Say, I want your number from you, give me stuff. Come on, be more fucking fun. I can know the doctor. Oh, my you by me. Oh, my God, but take Versace and a beauty. Don't take my rich at me. Oh, so you go. Be by the you go. When I drop my bed, you say, fuck with my son, no condom. Hold on. They tell us for and if they go and David, you will let you fall in see the lesson, man. I do not the beast in that line. Cinderella, back to it, one piece, one piece, one piece, one piece, I'm back to it, I'm back to it, you know, I'm back to it, I'm back to it, one piece, I'm back to it. I see, come in, Joe. Oh my God, what the feeling? Versace and a beauty. On the body, just really awesome. Choco, be body, choco. When I drop my bed, do the play, fuck with my son, no condom.
Conscious of food. If you not getting me, forget about it. Now by Lambo, is that why I shout? Them do, who let them do? No, they see them.
So welcome with me, James G. Okay, from the University of Pennsylvania. Thank you.
Thank you, Godwin. First, thank you, Godwin. Thank you, workshop organizers, for the generous invitation, the warm welcome. It's brilliant to be back in my homeland. Godwin didn't mention that, but I am a local. I wasn't sure if I was going to share the story, but I'll do it. The last time I was here, I traveled with to Farouk Dako, a great friend of ours. He's actually a colleague and friend of mine at the University of Pennsylvania. And he asked me when I landed yesterday, he asked, did everything go okay? Did they make you dance? Okay, so what was he referring to? He was referring to the fact that I'm sure all of you get subjected to this, but as a foreigner entering, the airport and landing, everything, you go through immigration and stuff like that. Then you have to get past that last gauntlet of the military security, who discreetly asks if you have any presents for them, right? And so the last time I was here, I was with Farouk. And we end up doing a little dance for our military security, and they let us pass after he and I did a dance for them. So he asked if I had to dance again this time. So guess what I did this time? I showed them my passport, and I told them to look at where I was born. So these 4 military guys looked at my passport, and they see Nigeria, and I said that I'm one of you homies, So cut me a break. And they laughed. They gave me a fist bump and they let me go by. So anyway, it was a great visit. Anyway, I love coming home. And so thanks again, Godwin. I'm so happy to be here, and in particular for the invitation to come and talk about some of the work that we've done in analyzing. Oops, looks like we lost. Should I restart? Oh yeah, sure. Go ahead. Oh, yes. Yeah, sweet. Oh, it's showing? Okay. Okay. Try it again. You can take that out. Yeah, you can take that out. Okay. Oh, good. Oh, good. All right. Let's see. Thanks again. Looks like we got the AV situation sorted out. Thank you again. Try again. Yep. All right, looks like we're back. So thank you again for the invitation to come and present some of the work we've been doing in analyzing the kinds of multifaceted features that we're able to more or less routinely these days extract from our brain imaging studies. And this is thanks in large part to the availability of computational pipelines that can now automatically provide detailed quantitative characterization of both structure and function in our multimodality medical images. Here are some examples of one component of our own pipeline in action across very different brain data sets. In particular, the images on the top row showed a relative cortical thickness or gray matter thickness computed within each brain, with the thinnest regions indicated in blue and the thickest areas in red. The pipelines also need to handle very different brains within our human studies. And here we see the differences in cortical folding and thickness across human development, as well as in a pathological state as shown in the far right column, in this instance due to frontal temporal degeneration. So several methods power our pipeline software, most notably the popular ANTS package for image registration. This is a very basic task of figuring out the coordinate transformation or mapping that identifies for a given point in one image its corresponding position in a second image, usually in such a way that brings common features in these images, for example, anatomy, into spatial alignment. So ANTS is a real workhorse for us, and I think it's worth spending a few minutes to expose you to some of the innovative concepts embodied in the core ANTS algorithm. And you have to forgive my shameless trumpeting here of the acclaim that the algorithm has received, but this is only because it's the beautiful thesis work of my former graduate student, Brian Avance, actually, who Danny Wang knows very well, and of whom I'm really very proud. So one key idea is that the correspondence mappings between different anatomies, in this instance, brains, or more specifically, images of brains, are optimized over the diffeomorphisms. These are just a set of differentiable maps, meaning you could take derivatives of them, with a differentiable inverse. So the inverse of that mapping is also differentiable. In other words, if you do this, the topology of the domain, in this case, the image that's being transformed or normalized, is maintained or preserved by the transformation mapping. These diffeomorphic maps are generated by integrating a time-dependent vector field. This is just a velocity field effectively over time, starting from X, the identity configuration. And the idea here is that by ensuring that the velocity field is smooth, the displacement mappings that we get from them by integrating the velocity field will themselves be differentiably smooth. In other words, there'll be diffeomorphisms. There are two constraints on the optimization problem. The first constraint is that at time 1, the diffeomorphism should map image I, shown on the left-hand side here, into the space of image J, shown on the far right-hand side. And the second constraint is that the length of phi, the length of the mapping, should be as small as possible. And this length is described by the integral over time of the velocity field size. So by solving this problem with these constraints, in other words, by solving the registration problem, we can smoothly map image I into the space of image J as shown here. And in this way, solve the registration problem. Here we see an animation of a diffeomorphic map, in this example between a chimpanzee brain and a human brain. Each frame in the time lapse of the movie corresponds to a point along the diffeomorphic map. We can get some additional insight into the algorithm by taking a look at how we discretize the problem. As we saw in the preceding slide, the dense in space and time velocity is sampled at a finite set of time points. And looking at the integral, we can see that the initial value of the diffeomorphism is just the identity, phi x at time 0 just equals x itself. To update the value over time, we simply traverse the velocity field, accumulating the deformation in small time steps until time 1 is reached. Now, as one might imagine, this looks locally at a voxel like a curve integral. And indeed, this is exactly what it is, except that it's spatially dense in a continuum instead of just at a single point, meaning we solve this over the entire domain. And so for that reason, a diffeomorphism locally over time traces out a curve, which is defined uniquely by its initial value, and that was the identity, if you remember, together with the tangents of the curve described by the velocity field Vxt. I noticed that the animations are not working, unfortunately, during the projection here. But in any case, so as I mentioned before, to optimize the diffeomorphisms, we basically manipulate the values of the velocity field. Now, it's important to note that this is a very different and a very distinct concept from just simply applying a series of incremental deformations to an image, something that's conventionally done to mimic large deformation transformations. And the trouble with this approximation that's commonly used is that it actually doesn't guarantee that the domain topology of the warped or transformed image is preserved. So you can introduce holes or tears and things like that. It also doesn't ensure that a proper inverse mapping will be available. And I'm going to show you very shortly why this is so important to be able to do. Now, there is, however, a very serious shortcoming of the approach that I've just presented, and in fact, with all registration methods in general. And that's the fact that the formulation and the viewpoint that it takes are fundamentally asymmetric. The path from image I to image J and the opposite or inverse path from image J to image I are not the same. In other words, the metric distance between our two images, between our two endpoints, that is the total deformation summed in time, actually depends on which image we choose as the reference point, whether I'm going from I to J or J to I. And what this means is that the direction in which a registration is performed actually makes a difference or matters in practice. And this bias is clearly a problem for the kinds of quantitative applications we're interested in for any of our imaging studies. So fortunately, there is a way to fix the problem. And to see this, the idea is, again, to generate the mapping phi in the same way as before as the integration of a velocity field. Except what we do now is we move the endpoint condition to the middle of the path by explicitly representing the component of the diffeomorphic map that operates on image J. And what this means is that the geodesics, or the shortest diffeomorphisms, the shortest mappings connecting the two images, are now required to be the same. This now gives us a set of symmetric Euler-Lagrange equations that depend on gradients of both images I and J, as opposed to just image I in the original formulation, which is the asymmetry that causes the bias in standard registration. Or if you had flipped things around, it would just been dependent on image J. The second important numerical difference is that the optimization now can also be carried out symmetrically. So we not only have a symmetric formulation, but the optimization can also take advantage of this. And the way we do this is we discretize in time the velocity field as we did before, except we then update the velocity field symmetrically from both endpoints with initial phi values, and then generate new phi values by integrating as before the velocity. And this process is repeated until convergence. Now, I think it's super helpful to actually take a look at the symmetric normalization in action, because the basic algorithm is actually so much easier to appreciate when we do so. So in particular, let's take a look as shown here at the sad face on the far left as image I, And the happy one in the middle is image J. I'm using smiley faces here only because it's actually a whole lot easier to show the effect of the algorithm with faces than say with brain images, unless you're super familiar with brain anatomy. So I hope the animation works. Yes, so note that where conventionally one image is typically deformed into the other, both images now deform into the mean or average configuration at time equal to 1/2. And the total symmetric normalization or path between the two images is obtained by composing these two diffeomorphisms that's shown here. So rather than going from sad to happy, image I to image J, or happy to sad, J to I, both cartoons first become sappy. All right, that was supposed to actually get a laugh, but you know, I often hear groans instead, and that's fair. But in any case, to go from sad to happy, for example, you start with the depressed state, you flow into the sappiness state that's shown here, and from there, you then take the inverse mapping from sappy to happy. The path from image I to J is now identical to the path from image J to image I. And what's even better is that this symmetric registration not only gives us unbiased results critical to quantitative studies, but also results in significantly improved performance because all of the images now contribute to the calculation, as we saw earlier when the gradients were shown to be taken with respect to both images in the pairwise registration problem instead of, say, with respect to image I or with respect to image J independently. This performance gain has been absolutely essential in making practicable what is now the most commonly applied approach for automatically segmenting or identifying the anatomy depicted in medical imagery. And the use of these anatomical parcellations remains perhaps the most popular method for hypothesis-driven analysis of image data. Now, just as a quick technical aside, I'm an engineering scientist, so I can't help myself. I'm going to do this. A very convenient property of the symmetric normalization approach is that it naturally generalizes from pairs of images, as you've just seen, to define a symmetric population or group study over an arbitrary number of images. And an easy way to see this is to note that the pairwise symmetric normalization algorithm that I just showed effectively solves the two mean problem. It solves the average of the two images. We saw how we actually solve for the average when going from I to J or J to I, and then transition with the mean or average configuration to actually get from I to J or J to I. Well, a population study simply corresponds to now a solution of an arbitrary n mean problem, n being the number of subjects in the group or population analysis. This is exactly what the generalization provides. It finds an optimal reference coordinate system or template I bar given directly by the n mean configuration, the average over those n images, which by definition maximizes the total length of the set of diffeomorphisms phi operating on each of our subjects, ji. And these diffeomorphisms are exactly the population normalizing transformations of interest to us in a group study. All right, so as I was saying earlier, region of interest analysis as enabled by atlas-based registration or the registration of parcellated volumes remains perhaps one of the most popular methods for hypothesis-driven analysis of image data. Now, for structures with certain geometries, we can actually extend the standard approach in a very interesting new direction. And shown here are the sheet-like fiber bundles seen in brain white matter that specifically motivated this development. And if the animation was working, you would have seen some beautiful fiber tracks there. I apologize that it's not working. Our method builds on the large body of work in the field that has looked at different ways in which to model and analyze the white matter tracks that can be visualized with diffusion MRI. And in particular, the two classical approaches shown here from the literature, namely the curve-based model from Guido Gehrig's group, formerly at New York, and the skeleton-based model from Steve Smith at Oxford. In Steve's track-based spatial statistics, or TBSS, the key idea is to take the data from three-dimensional brains of different individuals, and you collapse this 3D data onto a set of surfaces. These surfaces are the so-called skeletons of the white matter structures, as seen on the far right figure shown here, and then performing analysis on these surfaces rather than performing analysis over the voxels over the entire brain. And what this does is that's very helpful is to accomplish dimensionality reduction by using the most salient geometric features of the tracks or fasciculi for analysis of diffusion tensor imaging data of white matter. Now, at the same time, Gehrig's curve-based model is also really appealing because it provides a way to establish, it provides a very natural way of establishing a coordinate system or parameterization for each fasciculus of interest. And this is, again, really important in the kinds of group studies that we're typically interested in running. And it does this by using fiber tracking as a starting point to trace out a representative set of curves within the track. And these curves are then used to define a coordinate system for this fasciculus, as you see here. Well, it turns out we can actually combine the best of both of these approaches by representing each fasciculus by a surface rather than a set of curves. And this surface is actually essentially the skeleton of the fasciculus. Although we compute it very differently from the way that TBSS computes skeletons, we start instead from a set of fiber tracks that you can see in the left column here. What we then do is use a 3D deformable geometrical model to fit the tracks as close as possible. And the continuous medial representation model, the CMREP model that we use in particular, has some very handy special properties, including the fact that it provides an explicit description of its own skeleton. It also guarantees that this skeleton is a single surface, rather than the clump of surfaces that you ordinarily would say get in TBSS or other related approaches. And what you see in the last two columns now are two parts of our model: the boundary of the 3D, three-dimensional CMREP model around the tracks, as well as the skeleton of the model deformed to fit the tracks. So we get the same skeleton representation of our tracks, just like TBSS, but these are now parameterized surfaces specific to a given track, which, like Gehrig's curve-based parameterizations, allows us to do some pretty neat things. So for example, one practical advantage of the surface-based representation of white matter tracks is that it's perfectly compatible with fiber-based representations that are popular in the field. So as shown here, fibers can be tracked directly now on the surfaces themselves, as opposed to within the volume. And then with the help, for example, a Brodmann area atlas as illustrated here, bundles of fibers can then be labeled according to the Brodmann area near which these fibers terminate. And we can use this labeling to further subdivide white matter structures into subregions, allowing even more refined analysis of our data. Importantly, one thing that we'd like to leverage is that the fiber orientations can be useful for data analysis. So for instance, one can envision now smoothing image-derived measures, such as fractional isotropy, on the surface in such a way that the smoothing kernel has a different aperture depending on whether smoothing is performed along the orientation of the fibers or across them. In other words, we can take advantage of the track skeletons geometry to perform anisotropic smoothing of our data. We can also perform fiber-based cluster analysis, something, again, that's of interest to a number of folk in the community. Now, once we have these surface-based representations of fasciculi, we can perform TBSS-like analyses, but now focused on specific tracks of interest. The first step is to take the three-dimensional data and map it onto these surfaces, much like in TBSS. And that's what this diagram here is showing. It's basically giving you a local picture of what's happening. The red curve is a cross-section of the medial surface or skeleton, and the squiggly lines that you see here are the fibers passing near that area. The blue lines are the boundary of our model, basically showing you the volumetric extent of the fasciculus. Remember, these are actually three-dimensional volumetric regions. We can simply sample now the diffusion tensors along the direction normal to the boundary and average them to give us a single value now at the skeleton. Or we can mimic TBSSS by taking the maximum value along the projection. And the point is that we're completely free to choose how one would like to summarize the data in this way. And again, the point is that whereas in typical studies where the smoothing is isotropic, as I just mentioned previously, we can potentially now achieve a better trade-off between sensitivity and specificity by dimensionality reduction and smoothing on the medial surface. So by sampling in this way for every point on the surface of the geometrical model, we now obtain a set of values, one for each of our subjects, and that's what's shown in the figure in the lower right corner here, where in this case, the fractional anisotropy of diffusion tensor images is plotted for each subject on the model surface. And from here is just one more step for performing statistical analysis, in this case, just computing the T-map, which is shown on the lower left corner there. And these analyses can, of course, be carried out on more than one tract, as shown here. And so this track-wise framework, as presented, naturally applies to brain white matter studies for any of the diffusivity-based measures that can be derived from diffusion MRI. So we heard about ADC earlier, for example. But a potentially even more informative approach is to integrate these kinds of studies of microstructural features of white matter with investigations of changes in macroscopic properties of tract morphology, such as the size of our tracts, or tract thickness, or even the shape of the tract. These are measurements that are immediately available from our parameterized models. And here's an application of this kind of multi-scale approach in a diffusion tensor imaging study of amyotrophic lateral sclerosis. This is a neurodegenerative disease that affects the upper motor neurons, and so the cortical spinal tract is of particular interest in this kind of work. And as you can see, the thickness analysis highlights additional regions of macroscopic pathology, at least differences in the patients that we were looking at in this study, that are not found by just looking only at the microstructural FA, fractional anisotropy data in this particular case. So the analyses that I've talked about up to this point have all been anatomically defined or anatomically driven. On the other hand, what's all the rage right now, of course, are empirically based, data-driven approaches. And I expect that you're all probably thinking about neural net-based methods here. But what I'd like to take the time to do today is to advocate for more classical techniques that not only remain tremendously interesting, but are oftentimes much more accessible. These techniques take advantage of modern mathematical methods for matrix factorization that can not only be tuned for medical imaging data, as we've done in something we call eigenanatomy, but also for many other types of data. The motivation, of course, is that in spite of the proliferation of brain atlases that are now available for brain imaging studies, we don't always have anatomical regions of interest that are optimal for a particular study. And this is in part due to the fact that there's this persistent issue of disagreement as to anatomical definitions. But in the more common case of exploratory studies, there's also just a simple challenge that it's not always clear ahead of time how to decide which regions are of interest and at what level of detail for our analyses. Well, with eigenanatomy, we take a set of spatially normalized images and use a form of principal components analysis to decompose the images from p-voxels, numbering in the many thousands. This is across the entire image volume, into a set of reduced set of weighted regions of interest. And these regions are sparse and spatially clustered, meaning we can restrict the extent and a degree to which each region of interest can be distributed. The key concept here is that these regions of interest are defined entirely by the data. They are selected in such a way that the set of projections captures a maximal amount of the variance in the original high-dimensional data space, subject to sparsity constraints that we impose. The obvious idea here is that by sampling the data with these projections, we might improve performance, for example, on statistical tests in the reduced dimensionality space, because these regions now better and more compactly represent the variance in the original data. Now, the following study that I'm about to go over wasn't designed specifically to demonstrate the potential performance advantage with eigenanatomy, but it will give you an idea of how we now routinely use the method in our work. The input data here is cortical thickness and white matter fractional isotropy from, in this instance, 69 patients and controls. We use eigenanatomy here to find 32 principal components representing the FA data shown here on the left and cortical thickness data shown on the right. We then look for which of these regions are most predictive of cognitive performance on 3 different language tests, each of which designed to evaluate different aspects of language ability. And specifically, these included the animals category verbal fluency tests, which test the number of animals that one can name in a minute. Another test was the FAS letter fluency test, which counts the number of words beginning with the letters F, A, or S that one can name, and the Boston naming test, which is a picture naming test. The regression problem using the eigenanatomy projections as predictors now is now reduced to a determined linear system where we have fewer betas to calculate as a result than we have subjects, but in practice, really not by much. There are only very few degrees of freedom in the model. And it's also very likely the case that the betas will be non-zero for all of the predictors or these regions of interest that we extract. So we have to have a strategy for picking out the ones that are most relevant. This is a very common problem in linear regression, and there are a variety of techniques for addressing this, again, classical techniques for addressing this. Our approach is to run a sparse regression that lets us control sparsity just as before, and in this particular instance, by setting an upper limit on how many predictors can have non-zero weight. And here are the results of doing exactly that for the 3 language tests and applying cross-validation to the resulting models. On the horizontal axis is the number of predictors, the number of extracted components, and the vertical axis is the prediction error computed by Monte Carlo leave half out cross-validation for each of the 3 different tests. And it looks like here 3 or 4 predictors or components are just about right. And shown here are these components, are these predictors, the selected regions for each of the 3 different tests. The pink to red colored regions are regions in gray matter. So this is from the cortical thickness data. And the blue regions are in white matter. So this is from the fractional isotropy data. We can see some overlap in the language networks, namely the left temporal lobe features prominently in all 3 results, in all of the 3 tests. Fluency is also correlated with the frontal and cingulate areas, while structures most correlated with naming appear to be concentrated in the temporal lobe. Now, it's also evident, and this is always very nice to show in multimodality work, that white matter integrity plays a complementary role to cortical thickness, since the white matter predictors are consistently included, as we can see in the figures here. And here, the exact same modeling setup is used in a different cohort, in this case to predict an individual's score on a mini mental state exam. This is a test that's commonly used to help detect or diagnose dementia. So instead of language testing now, this is a cognitive exam. You can see on the right-hand side the quite convincing cross-validation performance that we were able to obtain at least in this particular experiment. Now, the story actually gets even better because the regression tool that we've developed and used to generate these results can actually be generalized to data that's sparse and multivariate on both sides of the equation. What we're all ultimately interested in is to be able to relate many modalities, each of which with potentially a very large number of voxels or entries, and by this I mean data sets such as genetics in addition to imaging. In this situation, we can compute dimensionality reduction for two modalities simultaneously by maximizing now the mutual information between the modalities. A version of this is the canonical correlation analysis that we favor, which you can think of simply as a multi-view extension of the PCA, of the principal components analysis approaches that I've just described. And to help see this, let's take a look at the specific question highlighted here, namely the relationship between gray and white matter changes in a group of subjects. This kind of question comes up very frequently and very naturally in, for instance, neurodegenerative disease. And I'll again use dementia as a specific study example. So what I'm showing here is how we might collect the data for CCA, for canonical correlation analysis of the kind of study posed in the preceding slide. On the left, again, we have these cortical atrophy images, in this case, thickness maps. And these are generated for each subject from T1 MRI data. And these are then aligned to a template space specific to the T1 data. We represent the thickness data in a matrix T, where each row corresponds to a particular position in subject space. So this is a very long row. On the right, the diffusion tensor information characterizing white matter is warped to a separate DTI template space, so it's separate diffusion tensor imaging template space. And I'm going to be using fractional anisotropy, FA again, to characterize white matter, and this is represented in the matrix F. An extremely useful feature of CCA is that it doesn't require that the two data sets themselves be spatially aligned, meaning the thickness data and the FA data. It's also not necessary that the number of voxels in the thickness data equal the number of voxels Q in the tensor data. And what's remarkable and really handy about this is that we're free to use completely separate tools to normalize the two types of image data that we have here. And this is an incredibly big advantage because we can directly make use of and apply all of the existing tools that are currently available and optimized for each of these modalities. Another very important benefit is we're not required to resample either image set, which allows us, again, to carry out the analysis at the highest resolution for each individual modality. The CCA itself, the canonical correlation itself, simply selects now a linear combination of thickness and FA, fractional anisotropy data in this instance, that maximizes the correlation between the two data sets. The vectors A and B shown here are the canonical components. These are the set of canonical weights on the original data that give the best projection when combined across all subjects of one data or one modality view onto the other. So PCA can just be seen as a special case of CCA when we only have one view of the data. Now, just as with PCA, we've been able to adapt recent advances in sparse regression that use penalized techniques to find which subsets of voxels in each modality best predict the other modality. And the size of these subsets is a controllable parameter that corresponds to the sparseness of the computation. We think that this new perspective has exciting potential for providing a more complete integrative depiction of both the kind and degree of structural pathology in studies of disease. As, for example, in the study shown here, where without going into the details of the study, let me just say that one is potentially now able to identify mutually predictive distributed regions from multiple imaging modalities that can be used to help distinguish between different pathological conditions as for example, shown here in this instance between frontal temporal dementia and Alzheimer's disease. I'd like to wrap up by inviting those of you who may have an interest to take a look at our freely available software resources and others to which we contribute that implement everything that I've presented today. You'll actually get to hear a bit more about one of these tools in the next session. So I invite you to stick around for Dr. Phil Cook's presentation during the masterclass this afternoon. And finally, I'd like to acknowledge all of our current and former lab members and collaborators who together are the people really responsible for and who deserve all the credit for everything you've heard me talk about today. They're far too numerous to name, except for one special individual who has had an outsized influence on our work. And that's Murray Grossman, who founded the Penn Frontal Temporal Degeneration Center. Murray and I were each other's longest collaborators. We met at Penn when I was still just a trainee, and we went on to forge a decades-long partnership during which the research at his center provided the biological and clinical impetus that drove many of the technical innovations for which a lab has become well known for. Murray's recent passing, this is an incredible loss not only to the field, but for the many patients and families all over the world that he and the FDD Center served. I wish to end by dedicating this talk to my friend and collaborator, Murray Grossman. Thank you very much again for the opportunity to tell you about some of our work. Hopefully some of what I talked about today was interesting to you. Thank you very much again.
Hello, thank you very much for that excellent talk.
Thanks.
I've never seen this many equations. This many equations.
It's a workshop. It's a workshop. It says a workshop.
Wow.
It says Smart Africa. It doesn't.
Smart, yeah, Dumb Africa. Yeah, Smart Africa. You have to be smart. You have to be smart to understand these equations, the differential equations transmitting from one end to the other. Image J to image I, normalization, and all that. So let me room for 2 questions. Thank you. Jones, let's have questions. Give them the mic. Jones has a question. Who is the mic? Why are the push? Okay, thank you.
Thank you, Jim. That's a lot of work and complicated. But if you are to simplify it for me, if for instance you have an image of my brain, analyzing it, what can you tell me about my brain? What kind of information are you able to get and tell me about the characteristics of my brain, whatever it is? Maybe you can't learn a new language, you are about that your brain cells are.
Yeah, no, that's a great question. You know, at the end of the day, you know, those of us on the post-processing and analysis end, we're rate limited by the data that we have. All right. So you all here, the MRI acquisition folk, the medical physicists, you know, you guys are the real IP. You know, you guys are the folk who are providing the data. You know, now in the era of AI, everybody's actually acutely aware of the importance of data. So no, so first it starts with all of the things that you've been learning about during this workshop, specifically on ASL. By the way, I apologize that I didn't customize this talk to include some ASL examples, but all of these techniques apply to any type of image data that you generate. And so the examples, you can swap out thickness, you can swap out FA, and stick in your favorite ASL, you know, derived measurement. Given that, you know, the answer to your question is really flip the other way around. What is it that you're actually interested in learning about your brain? What is it that you're interested in, you know, in a group of people, in a particular condition, or even just how we are normally? Okay. The beauty, of course, of MRI that we take for granted here is that it's an in vivo modality. It's a one modality that allows us to study the brain while you're alive. And that's what's so powerful about combining these analysis techniques with data type. But yeah, I mean, what is it that we can do in terms of answering questions? It's really, like I said, it's rate limited by the data that you're acquiring, which is why continuous innovation and MRI acquisition is so important. And then the other thing is just rate limited by your own creativity and your ambition in terms of the types of questions that you're interested in answering. You know, tools are available to tell you about things that are interesting in disease, things that are interesting in normal health. And all of these tools, the ones I've described, are open source, so they're freely available. You can toy with those. And like I said, this afternoon, one of our staff scientists will talk about one of these tools.
Yeah. Thank you so much. The things, just a follow-up to your question, one of the things that I've also discovered with image analysis is that, like you said, it depends on the data that you have. Daniel Alexander, UCL, who was working on the Human Connexome project, where they actually look at all the fiber tracts, you know, of the brain. And I asked him this question about, you know, the brain. And what they have actually discovered is that the connectivity, you know, of the brain actually differs among races. You know, and so the brain, the way the African brain connects, you know, where the fibers connect is different from the way other parts of other brains of other parts of the world connect, because it depends on which part is, you know, more active, you know, or more what do you call it, stimulated. So all these are the things that we actually learn from the brain. And like you flip the question, it depends on what you want to ask, you know. And I think analysis or image analysis, data analysis, neuroimaging analysis can actually answer most of the questions that we are coming up with right now, you know, to look at microstructure differences and things like that, to give us more information about how our brain interacts with the environment and even within ourselves. Let's have the last question, or the penultimate last question.
Hey, thank you very much, James, for a wonderful presentation. So my question is from the acquisition point of view. So I noticed you used in the explanations mostly T1 images and TTI images with the fractional and isotropic map. I want to ask, is that as much as we can use, or are there like other computational or post-processing possibilities available with each and every modality we can acquire, or each and every sequence we can acquire, or just mostly because they're anatomical or they relate to white matter structure and all of that? Thank you.
Yeah, no, thanks for that great question. So my answer is fairly similar to the earlier one I gave, which is that what I showed was sort of like what's conventionally the standard. So if you're doing this type of work where you're looking at gray matter differences, volume and thickness tends to be a very common metric that's universally used across the community. In terms of measuring sort of effects related to white matter, FA is again a very common metric. But yes, there's nothing stopping you from using your favorite measure, including any that you invent yourself. Okay. The one challenge, of course, is that, and one reason why there are sort of like these quote unquote standard conventional measures that are used, is that there's some common understanding among the community in terms of what they mean. Okay. So anytime you want to invent a new measure that you want to use in your analyses, you have to convince the community that your measure is actually doing what you're supposed to be doing. Okay. Having said that, even many of the commonly accepted sort of like measures are vaguely interpretable. So meaning that there's an accepted sort of interpretation of what they mean, but there's also controversy in terms of what exactly it is that that you're saying about your study when you use those measures. So it is open to you. You do have, the flexibility and the prerogative as a scientist to choose the measures that you want to use. And honestly, there are literally hundreds of papers published every year in terms of, new measures that people are extracting from the same type of data. And you as a scientist have to decide sort of like which ones are most appropriate, reliable and robust for the types of studies that you're running. But that's generally not the rate limiting step. It's not that we lack measures or metrics or analysis techniques. Most often the times it's actually the real practical challenges are collecting the data, finding the subjects to take part in your study, having the resources to image them, and collecting high quality data so that you can actually analyze, get good analysis results.
Thank you. So we have Elizabeth then.
Sure.
Where's the other mic?
Thank you very much, James G. I did a bit of image analysis and those physics were like, yeah, my question is, I'm very familiar with image J. Now, I'm very, and from my knowledge of Ms. High came before the J, digital subtraction and all that. I'm very conversant with image J. So can you just tell me what the difference is? Because now you're saying it flip from J to I and back. Is it based on the filter back projection and all that physics?
Yeah, so I never realized this potential confusion between what I was presenting and the software package ImageJ. I apologize for that. So when I was referring to ImageJ, that was just a variable.
Oh.
Yeah, so I could have said image A and image B. I was just talking about mappings between the two images. But since you brought up ImageJ, this afternoon you'll hear about ITK Snap, which is a direct, I wouldn't say competitor, but it's an alternative to a lot of the functionality that you get in ImageJ.
All right.
So you'll hear more about ITK Snap. Yeah.
Thank you very much.
There was one more question, I think.
One last question.
Okay.
Aris.
Excellent. It's okay. Very simple question, but when you showed those sappy pictures, they have the same contrast. How would one of them, the set phase, had a reverse contrast?
Yeah, absolutely. So great question. So Godwin, you didn't allow me to add more equations. So I had to put up the simple equations. My talk is not here anymore, but otherwise I'd bring up the slide. So yes, so remember when I mentioned that there were two constraints to the registration problem. One was the easy constraint for everyone to understand was that the length of the mapping was meant to be as short as possible. That's just a regularization. So that's just in other words, the least deformation that you need to do to one image to make it align with the other. That's one constraint. There was this other constraint, and this other constraint measures the similarity between the two images after you've done the registration. So that's where all the magic happens. That's where all the cooking and everything. So that's what happens. So yeah, so the software itself does not automatically recognize it. What the idea is that what I've described is actually the registration package is actually an entire library. So you can actually choose which metric to use that's appropriate for the images that you're using. Exactly. So in this case, I would have in my library the appropriate metric in that particular instance. And that's why, by the way, all the deep learning is actually interesting here because deep learning extracts features in a very powerful way. And you can use those features, deep learning derived features, to compute that similarity. Yeah. Again, you didn't give me enough equations. So,
For next workshop, we'll bring more equations. Thank you so much, James G. Let's give him a round of applause. Thank you so much. So we'll move quickly to the masterclass session for the biologist masterclass session is not going to hold. So we're going to merge all the masterclass sessions for this afternoon. And then we're going to have the talk book before the masterclass. Okay. So I think James Cook's time is 4 o'clock. Is he online? He's online.
Right.
Okay. So we can have his talk and have Mrs. Balogun take us through a masterclass session. Okay. Maybe an introductory masterclass session of what we're going to be, benefiting from and all that. So let's take Phil Cook now, and then we'll have a continuation of the masterclass session. All right, so let's give them Phil Cook. Yeah, over to you. Thank you.
Hi there. Thank you very much. Okay, so I'm going to go ahead and share my screen. And alrighty. Do you guys see the slides?
Yes.
Okay, great. Just checking you've got the right presentation. Okay. Yeah, thanks again for having me. I'm going to talk a bit about ITK Snap, which is one of the open source tools that is developed in the Pixel Lab, and I'll show some live demonstration and take any questions. So let's get into it. So what is ITK Snap? So Snap is an interactive tool for labeling anatomy and viewing anatomical images in 3D. It's an open source tool with binaries available for Mac, Windows, and Linux. So you don't generally need to compile it. It comes with companion command line tools for doing image processing stuff offline. And the vision of it is to be robust and easy to use. So I heard ImageJ was mentioned previously. So it's kind of a different philosophy to ImageJ, which is a very powerful tool and has a ton of plugins and capabilities. With Snap, Paul has tried to keep it as easy to use and accessible to a wide audience, and really just focused on a core mission of doing image segmentation and being able to do that interactively. So unlike ImageJ or Slicer, it doesn't have a ton of sort of add-ons, but it tries to be fast and easy to use. So just a little bit about the history. It started as a student project at University of North Carolina that was led by Professor Guido Garrig. Paul Yushkevich, who was a graduate student at the time, started to work on it. He's now a professor at Penn. Later, the original tool was integrated into the Insight toolkit, becoming ITK Snap, which was a very beneficial development for Snap and for ITK, as a lot of code from became contributed into ITK itself, and the compatibility with ITK has been really great for users like myself who develop other ITK-based tools. So in about 2012, the ITK Snap version 3 came out. So that had additional facilities for looking at multiple modality images as that became more common. And some of the training materials that are available online deal with ITK Snap 3. So you'll see that GUI looks slightly different. We're now into version 4, which has image registration, which we'll look at. But it's been a highly successful tool with a lot of downloads, thousands every month. The original paper, which if you use this in research would be great if you could cite, is now up to 5,000 plus citations in the NIH PubMed repository, and there's a big team. So more than 30 individuals have contributed to the code, which is on GitHub now. But the core team is Paul Yuskevich, Professor Alison Pouch, and Jalil and other developers. So I'm not really part of the core team, but I have used Snap for a long time. So as I say, it's open source. You can grab it from itksnap.org. The website is there, has a lot more sort of background information, as well as links to how to download the binaries. And there's documentation and tutorials with available data that you can get and work through. So integration with ITK has a lot of benefits. One of them is that support for a lot of different file formats. DICOM, NIFTY, those are the main two that I use, but the NRRD, the Meta, and other, there's many other ITK formats. And having that kind of stuff taken care of in ITK is really powerful because you have a lot of confidence that you can load the image and have multiple modalities or multiple different images and have the physical space, i.e. the patient space represented correctly in ITK. So if you're looking at the window there, like the crosshairs and the coordinates, there's a lot of work's gone into making sure that the images are the right way round, and what's marked as right or anterior is anatomically correct, which has been an ongoing problem. That I've worked in imaging for getting on 20 years, and it's been an ongoing problem of doing this. And now with deep learning, we're often going back out of physical space and back into just arrays of pixels. And that has created new challenges. So with ITK Snap, there's a real emphasis on having this physical space correspondence shown accurately across modalities, and now allowing you to register images. But the first thing I would talk about is the segmentation, which is the sort of core of it. And ITK Snap is a GUI tool first and foremost for interactive segmentation. And that can be anything from fully manual, where you take a paintbrush and draw your feature of interest. And then there are somewhat more automated approaches, and getting on to sort of almost fully automated things that are done interactively in the cloud and then return the results to you. I'm not going to talk about that too much because that's kind of a sort of new feature, and it requires some sort of back-end IT infrastructure for sort of specialized use cases. But I will sort of break down the sort of manual and semi-automated capabilities. So as you can see on the left there, manual, you can draw with a paintbrush, you can draw shapes. There's the adaptive paintbrush that tries to, when you click, it tries to smartly figure out what you're trying to draw. And then there's the label interpolation. So you can see in the colors there where a person has drawn a kind of crosshatch, they've filled in, some slices, and then the interpolator has filled in the gap. So it's a labor-saving device. And then there's classification tools to try and learn classification and do automated segmentation, which we'll look at. So yeah, there's drawing again with the adaptive paintbrush in more detail, and the active contours, which we'll demonstrate in a second. Okay, so now I will go out of this, and I'm going to go and pull up ITK Snap itself. I'm going to share my desktop again. Here we go. All right. So I've opened this DICOM image. So I show a lot of brains, but ITK Snap is definitely not just a neuroimaging tool. So here I've loaded a DICOM series that's a body image. So I'll try and move this thing out of the way. Okay, so let's try and so this is one of the tutorial example data sets. So if you go to itksnap.org, you can actually get this data and try this guy out. So here we are, just to orient you, this is ITK Snap 4. Here we have the cursor position where we are in the voxel space. If I pull up the image inspector, we can learn about the image. And it's
your screen.
I'm sorry, are you seeing my screen now?
No, not
Oh,
yet.
I'm sorry. Okay. Let me share. Is that better?
Not yet.
You should see ITK. All right, I'm going to stop again.
All right, that's fine.
Okay,
We can
now
see
you,
yes, we can see your
Great.
screen now.
Sorry about that. So yeah, this is one of the example data sets. So yes, so the image inspector here tells you about the image. You can adjust the contrast here, different color maps for display, image information, and again, this talks about the orientation of the image and how ITK Snap or how ITK is interpreting the physical space. And then we have an image metadata, which for DICOM has a lot of information, for NIfTY generally, slightly less. Okay, so we'll go into just segmentation of the spleen here. The manual tools are available, so I can do things like use the adaptive brush. You can adjust how this performs. You can try and click. See, if I click here, it kind of starts to get the edges, even though the cursor is, including some background, which is super cool. And then you can also draw. You can draw little shapes, but we'll get rid of that for now. So I'm going to show the automated segmentation, and we're just going to draw a box around the structure of interest, just to save our computer memory. So draw a box, make this a little bigger, make sure we've got everything. And it's good to check that in all three planes. So make sure we've got the full extent of it. Yeah, that looks great. And then we'll just hit and I'll click the initialize with current segmentation, so I can start off with the little bit I've drawn. And then I'll just adjust the contrast again. So now we see two windows. And one is the grayscale image, the original image that we're trying to work on, and the other is the segmentation speed image. So everything blue is background and is not part of the, and there's different ways we can make this decision, but this is just to sort of help the segmentation. So this is the interactive part. We can adjust these thresholds. I want everything I don't want to be blue if possible, but I also don't want to exclude, I don't want any blue in the screen itself. So we can set an upper threshold here and a lower threshold to try and get rid of as much as possible. Like so, it's probably about good. So after doing that, and you can do it with thresholding, classification, or other ways, but we'll then, it will help the segmentation out a little bit. So we've got that initial slice I just drew, but we can add these 3D bubbles here. So we can do something like that, and then we can adjust the size of those, and we can add and delete these as we need. So I'll make a few bubbles. Maybe one here, maybe one down here. Then we're going to say, okay, we're going to let the computer do the segmentation automatically, and it's going to grow this, and you can control how fast it grows and how smooth it is. So for very detailed things such as vessels, or very spiky structures, you want to make the smoothness smaller, and you can sort of see how it's thinking about it. But something that's very sort of smooth edges, we'll make this term bigger. This tries to stop the segmentation, leaking out into adjacent things, and keeps it smooth. And you can adjust the step size here. So I'm just going to let this run, and then we can run the semi-automated process, and we can stop that at any time, back it up. I'm going to try and make it go faster by making this a bit bigger. So now it's going to expand a bit more aggressively. And okay, it's gone too far now, so we're going to just go back to the beginning, and then Okay, I put some of these bubbles too close to the edge, so we'll stop it there, for example. And then, I can add more bubbles here, and we can carry on from there. So I can go back and add a bubble down here, and and you can see this changing in 3D. And so the idea of this is, a sort of nicely automated process. And I drew my initialization too close to the edge here, so you see it sort of leaked out a bit. But we'll stop there. And then we have the segmentation, which we can then continue to edit. So we can take these parts off too. We can render in 3D. And you can then navigate by looking at the structure in 3D. You can navigate in 3D with this guy, and then so I can choose this part and then see where it exists in the slice windows. So then we can edit the segmentation in 2D. I can take parts off. We can edit in 3D, so I can define a little plane here, and I can say like, cut that out. Update the 3D segmentation, and see I've cut a little bit of the bad segmentation off. So this is really powerful for you. So the 3D and the 2D, you can kind of work together, and you can navigate, see things in 3D, or you can see. Sorry, I'm going to hit undo there. That's an important feature. You can move in 2D and also see where you are in 3D. So that's an example of the segmentation. I'm going to go back to slides for a second. So again. So one other thing we have is the registration. So this does rigid or affine, which is sort of rotations, translations, and plus scaling. And it has both automated and manual registration, which is great because you can initialize things and see what's going on in real time. And these can be written out as ITK transforms for compatibility with other tools that read those, such as Elastix, Ants, and Greedy. So I'm going to pull up a registration example real quick. So registration, we have, let's see, we have the MR. Okay, you should see ITK Snap pop open now with a brain image. Do you guys got that? Okay. And we'll load a CT image. Now, when I zoom out, you can see these images are in a very different space. So when I click at an anatomical point in the brain in the MR, it's miles away from the same structure in this 3D. And this is a registration problem. They're both of the same person, but the CT and the MR machine just have different ideas of how to describe space. And so if I tried to register these images, naively, it would probably just fail right away because it would say there's no image in the same space. So we solved that by initializing. So what we're going to do is say align the centers of the two images. We're going to match by the image centers. And if you have two MR images, you can also match by centers of mass. With CT, that tends to go wrong because the intensities are negative often in CT if they're in those units. But you can choose. So I chose image center, and now things are looking a bit better. And with the interactive tool, we can start to help the registration a little bit. I'm not going to help it completely, but I'm just going to put things in a similar ballpark. And you can also adjust scaling, translation, rotation, depending on what you're doing. I'm not going to do any scaling here because I want to do a rigid registration. And we're going to use mutual information here. So this is a metric. This, I believe, also came up in Jim's talk of how do you align different contrasts. So mutual information is a very nice metric of how well do you predict one image from the other without assuming that, you know, bright things in one image are the same, are bright in the other. But the question is, you know, how well can you predict one from the other? And that's a very powerful sort of concept. And then you run the registration at different levels, meaning you shrink the images. And so what we're going to do here is just run this. And you see this takes a few seconds, and it aligns the two images pretty well. So after that's done, you can go back to manual and see, you see the rotations, the translation, everything's filled in with what the registration found, and then you can refine it further. You can rerun the registration. We could then switch. Once we do rigid, we could go to affine if there was a scaling component, say one brain was larger than the other. We can do that. But for now, we'll just close this. And now we can see the alignment is pretty much better. And this is really quite cool because this CT image, you can see it has like implanted electrodes. It's a very different image contrast. And so being able to see this and do this interactively is very nice. It doesn't yet do deformable registration. So if we were registering two different people and wanted to do very exact registration or register to a template, we would start it with this kind of tool, and then we could move on to one of the command line tools. Yeah, so I will now go back to slides. So, sorry, I believe I'm sharing the wrong screen again, so it's gonna resume, come back to me. Oh, there we go. And okay. So yeah, the companion command line tools are also bundled with ITK Snap and are available for everybody. C3D is an interface to doing general ITK image processing, so you can use ITK filters. The idea of a filter in ITK is that you have input or more than one input, you do some processing, and then there's output, and these can be chained together to do what you need. And with Greedy is a tool for doing deformable image registration. So that means it can handle sort of higher order deformations that I believe Jim may have talked about, but it can do those via the command line, and it can read the initial transforms from ITK Snap. Yeah, so in ITK we have this filter concept. And you can get ITK, and it has a C++ and a Python interface if you're into programming. But C3D makes that available as a command line interface, and it makes many filters available without programming and compiling any code. And we can chain things together in a sort of similar way. So just you can get that as a separate program from the ITK Snap page, but if you download ITK Snap, the binaries will also be in there. And there's help available for that, and it's a very long list of available commands now at this web page, or interactively if you type this. So the commands here in boxes are just things you would type from your shell if you're running C3D. So you can do simple stuff like adding two images together, multiplying two images together, or dividing one image by the other. but the structure of the syntax is a bit different to some other programs. So I can just sort of go through that quickly. It starts, obviously you start with the program name, you run C3D, you give it an image, and then there are commands which begin with a hyphen, sort of like how sort of Linux and Mac commands work. So you would type -info to get information on the image, and then you can change options or write output. So the commands, sometimes like you see -info is just a command by itself. It just says, give me the info of this image. Then there are other things that have options, like when you say -o, you then follow it with what you want to write out. So this example here very simply takes a nifty image and writes it as a meta image. And you can do that using ITK's tools without knowing anything else about those file formats, which is a really useful thing. So how to write these? We write them and we read them left to right, but you have to keep track of the order of operations. So the way that this works is using a stack, which means we can write a sort of equations with images, but without using parentheses or worrying about whether multiplication comes before addition. So if you have done computer science and stack math, you're probably familiar with this, but a lot of users, this is a bit different to how you think of an equation written down, but this is how we do it. So we take an image, it goes onto the stack. We put a second image on, we'll call that image B, put that on the stack, and then we'll put a third image on, and then we'll ask for info. So whenever you do a command, it works on one or more images from the top of the stack. So in this case, it's going to give us info on C. And so let's take an example of applying a mask. So let's say we generated a brain mask, and there were a variety of great tools for doing this, but wherever we got it from, ITK Snap or elsewhere, we want to now apply this and get the image of just the brain without the skull and stuff. So conceptually, we think of that as a multiplication. We would say head times mask equals the result we want. In C3D, those things are written out in a slightly different order. So we've got the stack here, we put head on, we put the mask on, we do the multiplication. That takes images from the stack and does the work. So we've got head and mask now taken off the stack and are in their little working area. Those go into an ITK multiplication filter. The result comes out and the result goes back onto the stack. And that's basically how all commands in C3D work. It's taking things off the stack, applying a filter, and putting a result or results back on. Then when we say, give me the output, please, that takes whatever's on top of the stack and writes it out, which is the result image. So it's a bit different because, as I say, instead of saying A plus B, we're effectively saying AB plus. And the reason for that is just to enable the commands to be written in a way that's clear without dealing with parentheses or operator precedence and multiplication before addition and stuff like that. You just read the things left to right, and then the C3D just does them as it goes. And so we can chain together something a bit more complicated. Say we want to multiply image 1 by the sum of image 2 and image 3, and that's just written out this way. And there's a YouTube video on the ITK Snap YouTube where I talk about this in more detail, and it's also part of the available online tutorials. So it's a bit tricky, but it does allow you access to really a lot of different ITK. I've shown you basic math like multiplication, but there's also thresholding, there's image processing, bias correction. You can apply transforms, stuff like that. So I am gonna stop there. I think I've talked for about a good amount of time, but so I will take a pause here and happy to take any questions.
Yeah, thank you so very much. That was also a brain. Yeah. Yeah. All right. Thank you so very much. That was a mind-juggling presentation. We allow for those who are not interested in the or are scared of the equations, we try to follow. It's a lot. Thank you very much. So we take some questions. 2 questions to be precise, still online. Any question? Any question? We didn't see the C3. All right, we're still trying to digest your lectures so very well.
Sure, no problem. Yeah, so yeah, I just please go to the webpage. I know I kind of speed ran through all that stuff, and it's often easier to sort of do these things yourself. So if you go to the website, there is a longer, sort of slower paced video tutorial from Paul Yushkevich, who's the main developer, and there's also the course. So there's a 90-minute or so short course that we gave, and all the data that I've shown, the body image, and there's a brain image too. You can download, and there's kind of worked exercises with PDFs. You can kind of go through the instructions at your own pace. So yeah, I apologize for cramming a lot of content into the time, but
all right. Thank you everyone that has been here since
Thank you so much.
Okay, then finally we are bringing the activity of today to a close. But before then, we'll give a few announcements. We're actually taking a tour around LASUT. By this time tomorrow, we'll be having, or earlier tomorrow by 9 a.m. to be precise, we'll have the masterclass session in a venue just opposite this building. It will be put on the platform. Our tourism is on Saturday. It's optional, so you have to pick up your ticket. The dinner is tomorrow evening, and it's also optional, so you have to pick up your ticket. Tomorrow, we are supposed to be adorning our t-shirts and our jeans because we'll be visiting hospitals and centers with MRI. So please feel free to visit the registration desk to pick up your own t-shirt. So tomorrow from 9 a.m. is going to be the masterclass all the way, where we'll break into our different sessions to have a masterclass. Once again, thank you for making today a beautiful day. Thank you for being part of Smart African Network, the 4th MRI workshop, and thank you for being you.
And I say you want some stamina with the rap, you know, I know the give it to me, yeah, I'm a shaky tipo.